in which case let's start the public board meeting, and welcome everybody to the public board meeting, which we are again having remotely via Teams. It's Mental Health Awareness Week, and I think that's an important event in any year, but it's particularly important, I think, in the current COVID lockdown period. I particularly want to welcome Beth Matthews, who is our network chair, joining us for this month's meeting. Beth chairs the LGBT plus network, and Beth, you're extremely welcome. There are no apologies for absence from board members, but Rebecca is not with us today, so we just sort of note that, I think. We have the minutes of the meeting of the 22nd of April. Are they a true and fair record of everything we discussed? Yep. Excellent. Few people are nodding, and nobody's objecting, so we'll take those as approved. There's nothing on the action log. Was there anything arising anybody wanted to raise that's not covered as we go through the agenda? Excellent. So can I come straight in to you and to Kate for the emergency support framework, please?
Thanks, Peter. I'm going to kick off with some sort of, if you like, background, and then I'm going to hand over to Kate to talk about some of the detail, and particularly around the experience that her and her team have had over the last couple of weeks of actually using the emergency support framework. So I guess in terms of what is the emergency support framework is the obvious first question, and it's worth noting that since the start of the pandemic we have stopped routine inspections, and I stress routine inspections. We have carried on contacting providers. For many providers, they'll be receiving phone calls from us on a weekly basis, and in some cases more often than that. We have continued to assess risk remotely. As you can imagine, during this time period, there's the normal data streams that we're used to seeing continue. Some of them have changed and been amplified and so forth, but the number of the normal data streams are there, and we've been looking at those. We've also been receiving information directly from the public. They've been contacting us on the telephone through our National Customer Service Centre, and you'll be aware that we have continued to be able to offer the full service from the NCSC during this time period. So with the NCSC colleagues working from home, so we know that the shop has still been open, if you will, for the public to contact us and talk to us. And of course, I'll give feedback on Care Service, which we launched some time ago. It has enabled people to contact us digitally. So there are a number of ways the public can talk to us. That's the public, that's members of staff. Again, we've had a number of members of staff talk to us about what they're seeing in providers, and of course patients themselves who perhaps have been in hospital, perhaps have come out of hospital. And of course, you know, being in hospital these days doesn't mean you're cut off from the outside world. You've still got your phones and tablets and so forth. So people can contact us in a number of different ways, and have continued to do that in numbers over the last couple of months while we've been in lockdown. And in a very small number of cases, we have actually gone out and looked at services. In some cases, we've started with a desktop inspection, if you like, an enhanced inspection, and in other cases, we've crossed the threshold and gone in. So we've carried on doing all of the same activities that one would normally expect of regulation. We've carried on being the regulator during this time period. But we also have tried to be cognizant of the advice from Public Health England that we didn't want to be a vector. We didn't want our teams going from place to place, walking COVID into environments where there were very vulnerable people being treated or were living. So that's always been a very difficult balance, but that's what we've been wrestling with over the last few weeks. It's also worth remembering, of course, that 8 weeks ago was the start of this, so it wasn't actually that long ago that we went into this COVID emergency lockdown period, which seems like we've been in for a long time, but it wasn't actually a huge time ago. So what we've been doing during this time, of course, is doing that routine regulatory activity. But we decided that we wanted to make that more structured and more formalised, and seeing if we could actually make some changes now, which would help us evolve into a new way of regulating in the future. So we want to just almost take advantage of the fact that we were in this lockdown period and could think quite differently. And I think one of the biggest changes we've made is to introduce this emergency support framework. And what the emergency support framework does is it takes a structured approach to assessing the safety of the care that people are receiving, particularly with a focus on the safety in the context of COVID-19. So as you would expect, the framework looks particularly at COVID-19 and how well a provider is coping with COVID-19 and the challenges that brings up. The framework is designed to be delivered on the telephone, so one of our inspectors would telephone a provider and ask them a series of structured questions. There's then a point scoring process, which Kate will show in a moment, and then that delivers a pro forma report, and we can then make a judgment as to whether that provider is managing and doesn't need any support, or whether they need particular support and what sort of support, and indeed who would best be placed to support them. Would that be someone from NHS England, for example? Would that be PHE? Would that be local support from a local resilience forum, a local CCG, and so forth? So I think depending on what we find will depend on who we call upon to provide that support. But the idea is to try and draw down support for providers. We're not in the inspection and rating business with the emergency support framework. And the framework can obviously evolve. So although initially it's going to be delivered on the telephone, if we start to feel that we need to enter premises and we can start to ask questions face to face, then we'll do exactly that, and we would anticipate doing that over the next few weeks. It is aside from looking at how well our provider is coping with COVID-19, it also looks at some very specific points. So things like Care Act easements, for example, is a provider in an area where they've decided that they're going to use the Care Act easements that are available to in some areas, and how well is the provider coping with that. And it's also designed to look at people's human rights. We're conscious that there are a number of places that are registered with us where human rights questions would rightly come up all of the time, and closed environments in mental health, for example. But in an area like a care home, human rights, the need to check up on people's human rights is slightly less obvious. But I think we're finding that obviously as care homes are closed, environments which were typically open are now closed, then this human rights question becomes more and more important in more and more providers. And again, the ESF seeks to make sure that's being considered by providers, particularly in environments where they haven't necessarily actively considered these things before. And it's just it's an opportunity for us to remind people they need to think carefully about how people give consent for procedures and so forth that perhaps hadn't necessarily been something they'd thought about before. So overall, it is a flexible, it is a digital methodology that we would expect to evolve rapidly over coming weeks. And as restrictions on movements change, we will be taking this methodology into providers in a very direct way. And I think I would expect that we will be doing more and more of this over the coming weeks, and we are talking days and weeks rather than months, where we'll be going in, and the tool will help us to target that work, so that we're not inspecting randomly, but we're carrying out assessments of providers on the ground in the way that we've always done. We might report on them slightly differently, of course. And I think the other thing that the emergency support framework does is it captures information in quite a structured way, which enables us to report on it and gain insight from it really clearly. So we'll be reporting to the public on what we find through the fortnightly insight reports, which are later on the agenda, where we talk about them in more detail. But as we get more information, we'll be reporting every 2 weeks on what we're finding via this emergency support framework. So I'm going to pause there and hand over to Kate to talk about her experiences over the last couple of weeks. Thanks, Kate.
Thanks, Ian. So just a couple of extra points to add. So obviously this has been designed at pace. It's had really good engagement from our inspectors in its creation, and it absolutely does, as Ian describes, it pulls together a number of different intelligence sources into a single suite of data that then informs that inspector's conversation with the provider. So things such as our new home care tracker tool, where we are asking home care agencies on a Monday to Friday to report to us about issues around PPE, workforce, testing, etc. All of that data is informing our daily conversations with providers. So we went live in adult social care about 2 weeks ago. What surprised me since we've gone live is the number of providers who have proactively contacted us as an organisation to say thank you for that supportive conversation. Thank you for taking action on the back of that discussion I had with your inspector. So there has been a notable increase in feedback we've had from providers telling us that it was an interaction, an experience that they've really welcomed. I just wanted to share with you as well, in the last week or so, I've had conversations with maybe about 200 of my inspectors to find out how they've experienced it and what their reflections have been since it's gone live. And if I may, I just wanted to give you quotes from two of my inspectors. So one is an inspector called Karen, who works in the northwest of England. So she said, not routinely crossing the threshold and undertaking routine inspections during COVID has allowed me to increase the monitoring of services at risk. For those at risk services, I've made calls regularly. The calls to providers have been supportive, and I believe not only have we monitored the service, but we've supported the provider to resolve issues such as PPE and understanding the multiple guidance that they've been receiving and trying to translate. So that was Karen's reflection. And then Rajshri, an inspector from Central East Midlands, said to me, the emergency support framework calls were well received by the registered manager, who reported that she found them to be helpful, and it formalised the regular calls that inspector had been having with those services anyway. She said that through these calls she'd been identifying best practice from conversations with the providers. So just to give you a couple of small examples. So we know from some people in social care, the impact of people who support them wearing PPE, so personal protective equipment, has been quite distressing. So she talked about having a conversation with a registered manager of a service for people with dementia. And she said that staff maintained social distancing by arriving at the resident's door without any face equipment on, interacting with that resident, so they established that relationship, and then putting the face mask on as they move into the room to deliver personal care. And then there was another example of a relatives and residents event, a sing-along event to celebrate VE Day that they did via Zoom. This service also regularly has relative meetings where 20 to 30 relatives are joining powwow calls to ask questions of the provider and to find out what's going on with the service. So this isn't just about us being assured about what's happening in terms of quality, but this is also a kind of two-way mechanism for us hearing about best practice and being able to talk about best practice elsewhere. And one final comment on the tool was from an inspector of mine called Holly, who said, it's a fantastic tool. I would like to see its functionality continue and develop, and there's real value of having the standardized sentences. So in your pack, you will see a format of what the emergency support framework looks like. There is a series of very targeted questions that our inspectors are going through with registered managers. These calls are varying in length. Some of them are taking an hour and a half. They are working their way through these focused conversations, but also these are often, inspectors are reporting, opportunities for registered managers to share a bit about the burden that they are experiencing with coping with events that they've never really experienced at this sort of scale before. So they are lengthy conversations that lead to action. Each of the sentences, the standardised sentences, generate a series of points that then leads us to form a view about whether the service is managing or requires support. And it's worth saying this is an intelligence-led process, but at every point the inspector's judgment can overrule it. So at any point, if the inspector needs more information or wants to understand something a bit further, they have the ability to do that. So far, we have initiated 1,466 emergency support framework conversations. It's a higher number than the number in your pack because this is the most up-to-date view of it. 864 have been completed, and that provider summary that's in your pack that has been shared shared with the provider. We are encouraging the providers where they feel it's appropriate to share that information with their local authority or clinical commissioning group in the spirit of transparency, but also avoiding duplication of a local authority or a clinical commissioning group asking similar questions of the provider that we are. In terms of what the data is telling us, so a lot of that will come out in the insight report that Chris will talk about shortly. What it can do is it can aggregate up the information that's coming out of the ESF to a kind of regional level or a local authority level. And the way that we're using that intelligence is that is then informing our regional conversations about risk. So we are able to say, we're noting an emerging picture in this part of the country with these sorts of issues. How are we going to respond system? But also it can do the reverse. So, for example, if a part of the country starts working underneath the CARE Act easements, we are aware of that, and we may choose to direct our efforts about where we're having those ESF conversations accordingly. So a strong start in terms of the kind of functionality and the feedback we're getting from providers. I do want to make this point really clearly, though. This is a monitoring mechanism. And it will always be limited by its very nature that it is a conversation on the phone with lots of really good intelligence. And there have been and there will continue to be reasons that we wish to still go out and cross the threshold. And those sorts of reasons might be in services where there is a closed culture, possibly historically they've been a service that have been inadequate or requires improvement, where we've been concerned about the service's ability to respond to requirements we've placed on them. And in those circumstances, we will be crossing the threshold and we will be undertaking targeted inspections. And as Ian said at the beginning, we were weighing up the risk of our staff going into services versus the risk of us not routinely having our eyes on what's going on in those services in person. I think as that risk shifts, I anticipate those number of targeted inspections increasing week on week now as we go forward. And we are absolutely set up as an organisation, as a staff team, to have groups of staff that are ready and eager and willing to undertake those targeted inspections. And there are other groups of our staff that will be supported to provide those more remote conversations and to use the intelligence. So it will be a team effort, but I absolutely anticipate the great work of the ESF being the foundations, but are starting to see an increasing number of crossing the threshold targeted inspections on the basis of risk, where we can't get the information we need remotely, and there is that real value add of us getting out and seeing what's going on in person.
Kate, that's brilliant, and Ian, thank you as well. And it just seems to me from what you've both been saying that this is not only a great response to the COVID crisis and the right response to what we do in the crisis, but in the longer term, it's a way to enhance our monitoring and focus better our inspection, and that's a really, exactly where we want to go. It links with our strategy, as you said, Kate, of being intelligence driven, and this is a part of the next sort of phase of being intelligence driven. So I think it's great, and thank you everybody that's been involved in developing it, Mark and your team and others, as well as thanks to all our inspectors who've been applying it. Can I step? Sorry, and you looked at.
I was going to say, and of course, the next steps we're just finishing off this week the training for PMS, so they'll be going live shortly, and hospitals in a week or so's time. So we've got a rolling program of launching this to the whole organisation. So yes.
Great. So can I open it up if anybody wants to either ask a question or comment?
Peter, can I? Okay.
Robert, please.
Thank you. Well, firstly, can I say that this is a fantastic development in a very short period of time. And I'm really pleased to see that priority was given to the adult social care sector for deploying it. The question really was this: there's, as everyone knows, been anxiety expressed in some quarters about our decision to stop crossing the threshold, although to my mind it's entirely understandable in the circumstances of this emergency. But I was just wondering, and I appreciate what you've said, Kate, about we will begin to start doing that again. This tool, as you say, is intelligence, and it's, of course, almost entirely, as I understand it, driven by information the inspector gets over the telephone from the care home provider. And I wonder how we triangulate that information. I mean, obviously a lot of it will be accurate and it's there and there's no problem, but I would sense that perhaps the home's struggling a bit. You would need to verify that, and I just wonder how you and your inspectors go about that, and in what way, and I think it is the case, that the way in which you support people you sense to be in trouble is a form of regulation, and it means that even if you're not crossing the threshold or other people are not crossing the threshold, the residents in those places are being protected by the support that's being given.
Thank you, Robert. So again, hearing from my inspectors, what they've said is because they are not spending the time routinely travelling to services, they are spending that time instead having much more frequent conversations with local authorities, with clinical commissioning groups, with advocacy organisations. So this is absolutely not just a one-on-one conversation between the inspector and the provider. It's using all that kind of collective knowledge. We've been hearing some examples over the last week where surveys that Healthwatch have done have brought back themes. Those themes have been shared with inspectors, and those have been followed up with individual conversations as well. So it is the whole suite of intelligence. We talked earlier about the importance of give feedback on care. So Chris can come in on this if needed. Obviously, we redesigned our approach to give feedback on care to make it easier for people to tell us about their care and to make it clearer and quicker. So clearer with what we do with their information and quicker for them to complete it. And we've seen a significant increase in the numbers of people doing so. Since the new give feedback on care went live in January, we've received 10,000 bits of intelligence, and that intelligence gets fed now into the ESF, so it's informing our conversation. So we've got whistleblowing information, safeguarding information, information from feedback on care, and then those conversations with other people in the system. And some of which, we're hearing examples where district nurses are providing really good hands-on care into services, and they are able to talk to us about their observations about how the services are coping. So where people are crossing the threshold, we are absolutely making good use of that intelligence as well to help us have that complete picture. I think there is more work to do about hearing directly from people with lived experience about their care, where they are maybe unable to go online and give feedback on care. So we are starting to think about how we might use our fantastic Expert by Experience resource to potentially think about how we gather some of that information directly from people who receive services and their families, their carers. And we probably want to come back and update the board on that when we're a bit further ahead in progressing that piece.
Thank you very much.
Can I just build on that, Kate's point as well? I think if I draw people's attention to page 18 of the diligent pack, or I think it's page 4 of the slide, there's a sort of master inspector's portfolio view, I think it's described as, and what that does is it's a summary of each inspector's portfolio. It shows the providers. It's been redacted in the blue box, as you can see on the papers, but there's a series that will list the providers in their portfolio. But then there's a series of remarks alongside it. We're talking about previous ratings and so forth, that they sum together to give the inspector a fairly high level view of whether the provider's high, medium or low in terms of risk. So when the inspector is looking at their portfolio on a Monday morning and they're deciding which calls to make, they have got access in one place to the entire regulatory history, in effect, in a summarized form. They can dig into that and look at the regulatory history on CRM and so forth. So it does give the inspectors a real sense of where the risk might lie. Based on that sense of risk, they can then decide which ones they do in which order, and in fact whether or not they want to go back a second time. I think it's also worth touching on the training that we did. I know, I've spoken to a couple of inspectors who commented on the fact that the training talked about how we question. This idea that they were given some conversational techniques during the training to make sure that they can start to draw out the information that they need. But I think, as Kate said, we very much recognise that there's an awful lot of information we can get from an intelligence point of view, but the fact we're in the COVID lockdown does create some restrictions on what we can do. But I'm hopeful that we can start to move to a position where we can address these shortcomings, particularly on the voice of people that use services, and get them into the mix as well. And we may end up with a sort of hybrid position where we can find ways to talk to people who use services at the same time doing relatively little on-site work, and certainly not as much as we were. So that again limits the risk of walking COVID into the service. So I think you're absolutely right to ask the question, Robert. This is by no stretch of the imagination perfect, but I think it's a very structured, thoughtful way that tries to bring the whole regulatory history to bear in making judgments. Thanks, Peter.
Thank you. Any other comments or questions?
Yes, please, Peter.
Yes, Mark.
It's a question to Kate. Firstly, thanks very much indeed for explaining the process so well and the intelligence behind the ESF. But I wanted to just look at two sections in the report, which was staffing arrangements and protections from abuse. And we know from Walton Hall that these two are very closely linked in toxic cultures. So I'm just wondering how we are ensuring that ESF flags up the warning signs such in closed and in open sites, such as high agency use, multiple shift patterns, inadequate line management training, high turnover of substantive staff, absence rates, vacancy rates. So just wondering how that's being picked up to come to a view on the location.
Kate?
Yes, please forgive me, there's been a power cut, so I'm on my phone. So thank you, Mark. So we obviously have that suite of data, and those are the services that we have prioritised for our ESF conversations so far. I think, as I said, there is some really helpful information that those conversations will give us, but there are types of services, types of environments where nothing beats crossing the threshold. Nothing quite gives us the information that we need when we go out and we do a short observational framework piece where we sit down and we just observe how staff are working with the people they support, and we note that and we give feedback, etc. So those are the services that I anticipate us starting to cross the threshold with more. I don't know whether Ted wants to say a little something about the Mental Health Act assessments and the fact that we have continued to keep those crossing the threshold inspections up through COVID.
Ted, you're being invited.
Yes. So I'll just go off mute. Yeah. Can I just say that we're looking forward to starting to roll out the emergency support framework in hospitals. Hopefully at the beginning of June. That's where we plan to do it. We'll be doing it in selected subsectors of hospitals. But I think it's very important to emphasise we're not waiting for that. We've got many other sources of intelligence that we've continued to monitor throughout the COVID epidemic. Give feedback on care has been mentioned, but of course we've still got whistleblowing, and we put out a message. Your board members will remember at the time of the last board emphasising the importance of people speaking up. And of course we have monitor serious incidents and outcome data. So we've got all that intelligence, and that will drive responsive inspections going forward. We've already done some, but they will get increasingly as the prevalence of COVID-19 in the community reduces, the risk of doing inspections becomes less. We will be looking to increase our responsive inspections, as Kate described in ASC. And I think it's important to emphasise that we are targeting areas where we feel there is risk, and we will go and cross the threshold in those cases. In terms of the Mental Health Act, to answer Kate's specific point, we have developed a new way of reviewing the Mental Health Act using some desktop and remote review of that. That is actually working very well. It has worked very well during the COVID epidemic, and I think we have learnt from that and we'll want to build on it. But that does not exclude us crossing the threshold and reviewing face-to-face where necessary, and it will continue to do so.
Thanks, Ted.
Peter, could I ask a question?
Liz, please.
Yeah. Firstly, I mean, I think it's absolutely right that as this infection risk does reduce, that we are becoming ever more active in crossing the threshold and, if you like, shifting the balance towards our full regulatory role, because I think that's very, very important to people in this time. What I wanted to ask was, it seems a very powerful tool that the inspector can see in one place everything that's relevant to that particular facility. And I remember I think it was in the Glynis-Murphy report, that was one of the points that was pulled out, that actually in the past, where systems weren't quite so sophisticated, inspectors had to look in a number of different places for different previous reports or previous sources of intelligence from whistleblowing or complaints or whatever. So I just wanted to know whether I'm right in thinking that this tool, in addition to being useful at this moment, will help with that point, that will give inspectors right across our work a really consolidated set of information that means that they really have everything at their fingertips to draw the best possible conclusions.
Could I perhaps answer that one, Peter?
Yes, please.
So absolutely, Liz, that's the intention. Right now, we've stood something up at incredible pace that allows us to gather the intelligence that we have to enable inspectors to make good risk decisions about where to focus their attention, and to also capture that in a structured way. So we've got our initial minimum viable product, which is out there and live, and being very successful, and we'll continue to add to that as time goes on. But right now, we've already seen how we've been able to bring together those the pieces of information that you've described, and we'll continue to expand and develop that to give inspectors more and more as that information becomes available. Great,
thank you. Any other questions?
Peter, may I ask a question?
Sure. Please.
Particularly addressing Rosie and Ted, really. Will the ESF for those sectors start to understand whether providers are beginning to pivot their responsibilities towards non-COVID work, which is going to be important? And I'm minded that in terms of chronic disease may increase as unemployment increases. Will we be looking at that as part of the assessment?
So, John, thank you for that question, because I think it's something that's on all of our minds in terms of how do we support services to get back to delivering more routine care. And I know I have concerns about the impact on the non-COVID services that haven't been provided during this period of time. The ESF will support us to be able to look at how practices in general practice are returning to routine care, and we will be looking at that, and that looks both at what happens within the practice, but also things like the referral pathways and how people are working with other providers in the local system to be able to make sure that people get the care, because we know that we are hearing some anecdotes about people not having referrals accepted and things like that, which we need to follow up. I think in terms of the routine care, the other thing to mention is that it is an opportunity for us to capture the innovation that's happening. There's lots of great work in terms of what practices are doing in terms of doing long-term conditions management in a remote way, for example, for the things that they can do. Immunisations happening out in car parks to reduce the risk for babies, and whilst it's probably not a long-term solution, practices are finding their way around how to deliver routine care, and this will enable us to pick up those really good examples and be able to share those in a proactive way, so that practices that aren't so far ahead in their thinking around that can learn from others.
Can I just come in there? Peter, is that okay? So just to reinforce what Rosie was saying there, we are very keen to see the re-establishment of non-COVID services as effectively and as soon as possible, as long as they can be provided safely in a situation where COVID is present. And I think one of the strong drivers of that is going to be really good infection control, and we are working with NHS providers across the board to make sure they are implementing most effective infection control so that they can build up their non-COVID capacity as quickly as possible. So I think this is very much a focus of our work at the moment. And of course, as we introduce the emergency support framework, we will build those questions into it.
Thank you.
Good. So let's move on. I'm not going to try and summarise the discussion we've just had, other than to say I think there are some very strong themes that come out, that we all recognise there are circumstances where crossing the threshold is essential. I think we all recognise that we are a regulator, not an inspectorate, so inspection is only one of the things that we do. And what I love about the tool that has been developed as we move out of COVID, as well as in COVID, is that it enhances our monitoring capability and capacity, and I think that's a really important development as we move on our regulatory journey. So I really would, as I said at the start, congratulate everybody that's got us to this point, and look forward to see how it develops in the future. With that, if everybody's happy, let's move on, if we can, Ian and Chris, to the insight. Ian, do you want to introduce this, or do you want to go straight to Chris?
Can we go straight to Chris, please?
Straight to Chris. Chris.
Okay. Well, as you've seen from the previous item, through our work as a regulator, CQC is developing powerful insight that helps tell the story about what's happening to health and care at the moment. As a crisis unfolds, we'll continue to review the information that we collect from others and that we have ourselves about what's the impact of the pandemic on people who use services, and also those that provide care. The purpose of the report, which I'm going to introduce today, is to make that available, that data that we collect, available as part of our regulatory activity, so that we can build a clear picture of the impact of COVID-19. By offering this transparency, we hope to guide decision makers now and inform the planning for the future. By regularly updating and publishing this report, we want to show what is changing over time, and we will identify improvements that are visible or where the picture is potentially deteriorating. As you know, there's often a natural focus on what's not working, what's going wrong, and this is inevitable, but it often will worry service users and anyone with relatives in hospitals or in a care home. The vast majority of care in this country, as we've seen from some of our early work in ESF, is still being delivered well by dedicated and professional staff. Our analysis aims to offer some proportionality and balance to the fast-changing and turbulent period where concerns are raised. We put them into context and show that things are working well in some areas, but where they're not, how we encourage leaders, both national and local, to take the right action. In this first edition of the pack, it includes information on outbreaks, on deaths, on testing in adult social care, PPE in care, in home care, and the wider effects of COVID on social care, on the social care system. Both our own analysis and what we've gathered from our regulatory activity and other partner organisation. As I say, the document is designed to prompt discussion and confirm the action we intend to take as a regulator. If I will, Peter, I'll just touch on a few of the themes of the report and then invite questions if that's okay.
Yes, please.
So one of the first things was around a significant improvement. There has been an improvement in the use of PPE, but what we want to make sure is that in all environments, all colleagues have the right PPE, the right training, the right support to ensure there is effective barriers to infection, and we are prioritising this work as part of the ESF that you just heard talk about. On wider infection control, NHS England have recently issued some guidance on infection control for health and care services during the epidemic. These standards need to be implemented in all areas, including communal areas for staff, patients and visitors. We've had some reports from staff that they share concerns that infection control standards are not being implemented consistently and effectively in some non-COVID and communal areas. CQC is exploring with system partners and with individual providers how to address these concerns and how to minimise the risk of cross-infection. So make sure we want to make sure we have the appropriate assurance, and that we want to make sure the standards are being managed consistently. We'll also share good practice where we find it, and where we'll seek further assurance where we know, including targeted inspections, where we know there are ongoing problems. We remain concerned about the discharge of people from hospital into adult social care settings without appropriate information sharing that allows care settings to make the appropriate assessment of risk and make sure residents and staff are safe. We are investigating a number of cases where care homes have told us that this has not occurred, and will take action where appropriate. As I think we said on Monday, we have ongoing concerns about closed environments. Partly about how they're managing a COVID situation, partly about how we ensure that they continue to provide safe care. And as we discussed with the JCHR on Monday, we intend to continue and increase our inspection activity in this area. As the infection rate declines, we want to test how NHS primary care and adult social care services work together to prioritise the reopening of care for non-COVID patients. We want to be clear about how services understand the risk in their area and how they safely improve access to care for different groups. And going forward, we'll focus on other key topics, return to issues around social care, but also talking about other issues like dentistry and how that can be opened safely to provide care. We will use examples of how technology is changing the way health and care services are delivered and what that means for the future of care. I hope colleagues find it useful. As I say, this is a first edition. We aim to ensure we have a regular drumbeat of this communication to help inform decisions both nationally and locally.
Thanks, Chris. I think it's probably important just to recognise that the slide deck is data up to the 8th of May, I think. So, there obviously has to be a cut-off point to get papers to the board. But we as an organisation obviously have data coming in on a daily basis. So from our internal point of view, it's more up to date than this. And probably the other thing to say is this isn't a complete suite of data that we have. This is the stuff that we want to put into this deck. And I think it's really good. So thank you. Ted.
Thank you, Peter. Can I just welcome this report? I think it's excellent, and I think it is a great first report, and as Chris says, we will be able to build on it going forward. I think the point I want to make is a more general one, which has come very clear out of the COVID epidemic, and that is the importance of transparency about information and data. And I think this report is an exemplar of that. And we've learned in the past, and I think COVID-19 epidemic has taught us again, that transparency drives safety and it drives quality. And it is really important. And it's certainly one of the things that I am going to be championing at the National Quality Board when it next meets in a few weeks' time. I think there's a real opportunity to build on some of the sharing of data that's taken place during the COVID epidemic to build up to a really transparent system. And that will enhance trust in the system, which is vitally important. But it will also mean that issues do not get hidden, they get addressed, and groupthink is challenged. And I think that is really, really excellent. So I think there's a real positive we can draw from this, and I think this is a great example of it.
Thanks, Ted.
Peter,
John.
Thank you. Firstly, Chris, thank you to you and your team for an excellent piece of work. Appreciate it. And could I just briefly endorse what Ted just said then? I think transparency of all organisations in the data they have that facilitates our understanding of what's going on is really important. People have a moral duty to do that, but I would also say a COVID duty to do that, that until we get that transparency, we limit the trust and confidence that is necessary as we come out of the lockdown. So I would encourage those who have difficulty getting to that point that they reflect. I have a couple of questions, if I may, for Kate. The first is that I'm told that there is low confidence in the testing system that is being applied to care homes in a way that gives confidence in the safety of residents, which is, of course, part of our purview as regulators. What is your view?
Thank you, John. So I think we welcome the clarity of guidance around this now. So the guidance is now there should be whole community testing. So not just testing of symptomatic residents, but testing of asymptomatic residents and of staff. So really welcome that is the guidance. Welcome the commitment that's been made that testing should be made available to the social care sector in its entirety. Obviously prioritising care homes in this initial window. I think it's really important, and I think what's shown in our insight report, that there is still an absence of clarity about who is doing the testing and how it should be accessed. So you may recall in the early days of COVID, in the absence of having the national infrastructure within adult social care similar to that of our health colleagues, we supported the department with our kind of address book and our relationships with social care providers to facilitate the establishment of care worker testing. And then we also supported the department and PHE with the piloting of residence testing. So I think through that process we ended up supporting about 32,000 people to access tests. We have now firmly handed that over, so there's now a government portal that people should be accessing. But as we say in our report that we published, some providers are still reporting challenges about getting access to testing in a timely way. So this is not being resolved. This is still an issue that we're hearing from our providers.
Thank you. And my second question, briefly, Peter, if I may. Care workers have done an incredible job. They are as heroic, as exposed, as traumatized as other people in the system, particularly when they've had several people sadly dying, who they may have looked after for a very long time. And added to that, the stress and impact quite often of going back to a low-income home. This will have an impact on their mental health. What support is available to them to assist them in that process?
Thank you, John. So my hope as we come out of this is the focus and spotlight that has been shone on social care during this terrible crisis, and it feels like the glimmers of recognition about what care workers do. It feels like as a society we're starting to talk about it more, we're starting to recognise the highly skilled, very challenging job that these colleagues do. My hope is that going forward they continue to have, they establish and continue to have the recognition and reward that they deserve. The issue around support, so we are, again, in our conversations with providers, we are hearing from very distressed providers, distressed registered managers, distressed staff. My inspectors have often reported speaking to people who work in care in tears, describing, often people who work in social care are used to supporting people at the latter stages of their life in those final weeks and days. What they're not used to is dealing with it at the scale that some of them have experienced during this. So we are absolutely hearing the distress this epidemic is having on our social care workforce. My understanding is the Samaritans have extended, so they've got a confidential helpline for staff during COVID that was initially available for the health colleagues. My understanding is as of the 15th of March, that's now been extended out to social care workers, which we'd really welcome. And what we'd really encourage is at any point when there are new initiatives thought about for the health workforce, so if we think of the early days of COVID, when health workers were supported to access supermarkets earlier, and the suite of other support the health workers offered, our ask is at any point we are having a conversation about support and benefits to health workers, we are in tandem saying that we need to be offering the exact level of support and assistance to social care workers as well.
Thank you.
Kate, going back to what you were saying in answer to John's first question, I know board colleagues know this, but it's probably worth being absolutely clear. At no time have we been responsible for testing, nor have we actually done the testing. What we were doing was facilitating the booking of tests. And I know there's been confusion, so I think it's important to be absolutely clear what our role was and what our role was not.
So absolutely. So we are taking every opportunity to remind people. So what we did was a booking function. We are no longer doing the booking function, and this is where you need to go to. The reason why we talk about it still as being an issue in our insight report is inspectors are still having regular queries from providers. There still seems to be some confusion about whether we have an ongoing role in testing, and we absolutely don't.
Yeah. Thank you. Anything else? Anybody wants to?
Peter,
sorry, yes.
Oh, Peter. Oh, sorry.
Go on, Liz.
Thank you very much. Yes. So I, like others, I think the transparency point is hugely important, and I think it's very welcome that we're going to be publishing everything that we know suitably analysed in these weekly or regular briefings. So I think regular insight documents. I think that's really, really important. But I just wanted to pick up from the point that was being discussed a moment ago about how maybe initially the biggest focus was on the NHS, then it moved to care homes. And I just think one of the purposes of transparency and benefits of it is that we can highlight other groups of people who may need attention, that not getting the same level of attention. I'd just like to mention people who are subject to the Mental Health Act, where we are seeing high levels of deaths, which I think are very concerning, particularly if people are compulsorily detained somewhere where they may be exposed to infection, and they're not able to they're not able to exercise choice themselves to do something about that, as also obviously applies to a lot of people in care homes. But I just wondered if I could ask, in relation to people subject to the Mental Health Act, I know it says in the document that we're reviewing data to understand the factors more and see what action might be needed. What exactly are we doing? What more can we do to satisfy ourselves that organisations are doing what they need to do to protect the health and well-being of people who are detained?
Can I come in there, Peter?
Yes,
so as part of the work we're doing on infection prevention and control, that applies to all NHS trusts, including mental health trusts and including people detained under the Mental Health Act. And we'll also be rolling that out to independent providers of services for people detained under the Mental Health Act. So we will be reviewing the quality of the infection prevention and control arrangements in all these providers going forward, making sure, as Chris mentioned a while ago, that they are complying with the latest guidance from NHS England on that. And I think that has to be the starting point to make sure the best possible infection control procedures are in place in all settings for all patients, regardless of their reason for being in a hospital or detained. And I think that's really very important. In terms of the specifics of issues about Mental Health Act, of course, we published this data, and again, that just feeds into the issue about transparency, that this was data we knew and we thought should be put into the public domain so that everyone was aware of it. And as the people know, Kevin Cleary wrote to all the mental health providers just to highlight the issue of this data and the importance of infection control. Where we are seeing any patterns in the data, we are going to go and look at specific areas, and we are following up with one or two providers, specific issues with them at the moment as part of our regulatory process. And of course that may trigger further actions such as inspections, which we are very ready to do if we feel there's a problem that we need to identify.
Thank you.
Liz, can I just come in there as well? Just to let you know, the safeguarding group across the CQC is doing some work looking at specific population groups who may be vulnerable as well, and understanding how we capture that data and capture particularly around the information that's coming through NCSE, so that we can get a better understanding of impacts on vulnerable population groups.
Peter?
Mark, please.
Yes, I wonder if I could just build on John's point about the impact on care staff and Kate's response to that. We already use our national voice to promote career pathways in the care sector and the development of management skills. I just wonder, Kate, particularly if you felt there was an opportunity for us to be using our voice to promote a sort of occupational health infrastructure for social care providers, especially those smaller operators.
Thank you, Mark. So I think, so when I think about our role in terms of the social care workforce, I think we have an important role to play in terms of shining a spotlight on what they do. So we're going to be talking, Chris, in the coming weeks about inviting providers to tell us about how they've responded to social care and to give us those real life examples that help describe how a care worker is having a positive impact on someone's life as a result of how they're working together. So I think we have a job in terms of celebrating the success of the workforce and talking about what that looks like. We've talked before in previous State of Cares about the importance of the social care workforce in terms of having a career pathway, in terms of reward and recognition, in terms of working closely with health professionals so that they can provide kind of high quality integrated care. And I think it's important that we continue to do that. As I say, there has been moves to talk about how, so if I'm wearing my care badge here and I've been wearing it, as you know, for about a year. In the last few weeks, obviously the government has been promoting the care badge and trying to encourage the notion of an identity for the very disparate social care workforce, and a badge that's about an identity that also gives you opportunities similar to those that colleagues have in the NHS.
Peter, here's Paul. Could I ask a question?
Paul, please do. Yes.
Thank you. I'm going back to the pack, if you like, and the data that's in there, which is fascinating to see brought together in this way. And it struck me that there's a lot of data there which potentially provides intelligence in some form or fashion. And if you say that at the moment 1/3 of care homes have been affected by COVID, in other words, they've had infection, I guess, and 2/3 have not. And we've seen the sort of geographical spreads. We've got lots of data coming through from at the moment from our emergency support framework things. How are we putting all that together in a way which actually starts to say, help people identify what the issues are that lead to some places getting the infection and others not getting it, and perhaps the severity within a particular care homes, whether it's spreads more widely within a home or not. What are we learning from that we can share and reinforce the defences, if you like, around those that haven't had it yet?
Kate, do you
No, you go first, Kate. Sorry.
I was going to say, Kate, do you want to start and then Chris, or the other way around? I don't mind, Kate.
So thank you. So there are many factors at play. Ted was talking earlier about good infection control. So our sectors have been talking a lot about access to personal protective equipment, which is really important. But that is a component of having good infection control processes in place. There are sometimes particular challenges in the social care sector. So if we think about our different residential and nursing buildings around the country that may be small or old buildings, the challenges about being able to physically space people out, the challenges about supporting someone who may have dementia and as a result of their dementia may need to move frequently throughout the home that they live in, and actually to be restrained or restricted to a part of the home wouldn't work for them. So there are many challenges. We welcome the commitment that no one should be leaving hospital without a test and those test results known, so that a care home, when accepting a new person into the service, can do so fully informed about what their needs are and how they should be cared for. We are really keen, I think, when we think about the insight report going forward, so obviously this is our first one, but to talk more about these are the ingredients, these are the components that means that we're seeing the right outcomes for people. So whether it's testing, good infection control, whether it's how the staff are working, for example, how the local health community is supporting that service. I think we will, in future publications, be talking more as well about what good looks like in terms of supporting services to not get infections, and if they get infections, to manage it in as a contained way as possible.
Just to build on that, the areas of focus, which is the last section in the report, talks about the areas that we want to concentrate on. It talks very much to what Kate's just said in terms of trying to understand the balance between people's compliance with the guidance, how services from different sectors work together, and how people respond to the challenges around training and support. And I think one of the things, the challenge of these documents sometimes is to, by the time we were definitive on the answer, we would not be transparent about sharing information. So that the information is shared deliberately, so that we share the insight, so collectively questions can be asked. And the reason to put those 4 areas of focus in, they won't be the only things we cover, but they are important, is it speaks to the issues that we think some of the data raises that we want to explore again. And I think in future editions, as well as our own voice, I think we want to try and bring the voice in of other experts who have a view in this area, so we can get a balance of understanding about what's happening. This is about driving. I think this is very much about, in our space, of driving improvement in all the sectors that we regulate. So I wanted to be clear about what we knew, clear about what we thought we wanted to do next with it, and also in future clear about what the answers to some of those questions that we've raised in this first edition are.
And can I just come in as well? Sorry, I just wanted to say, in terms of those priority areas, I think that the system-wide working and how systems have worked together across this, we've seen some really good examples of system-wide working. We've seen some examples where it's not worked very well, particularly between health and care and that interface. And I'm really keen that we quite quickly understand how we can explore that in more detail, and the Integrated Care Board is looking at that at the moment.
Thank you all.
Peter, can I just again, I think Paul makes a great point, and I think Chris, I just want to build on Chris's answer. There are some things that we as CQC can interpret from this information, and there are things that we as CQC can do. But if I just look, for example, at page 10 of the report, there's a line graph that shows numbers of outbreaks per 1,000 population, and I think it's it was well documented in the news media that when this was first, when outbreaks in care homes were first talked about, Northwest and Liverpool in particular were in the news, and you can see from the graph that early part of April, you'll see large numbers of outbreaks in the Northwest. But whatever the Northwest system did over the next few weeks to get on top of that outbreak was impressive. So in some respects, we may not know the answer in detail yet, but if I was a system leader in one of the other regions, I'd be picking the phone up to the people in the Northwest to understand what they did. And I think that's an example where just the transparency point that people have made, that the notion of just exposing the data means people can draw some conclusions really quickly. And there are some things, of course, we can get into forensically and look at as well. But I think for me, one of the great opportunities around this information is it will accelerate the collective response, both from us but also the wider system, which I think will be really, it can be really exciting, frankly. And also I think it's always important as we go through these sorts of things to make sure that people are capturing what they're doing. Because if we ask the people in the Northwest in 6 months' time what it was they did during April, they probably won't be able to remember in enough detail to really get the insight. So this provokes that active learning as well, which again I think is a core part of our purpose around promoting improvement. Thanks, Peter.
Thank you.
Peter, can I ask a question?
Robert, please.
I was going to say a lot about transparency, but everyone has said it, and I just wish to endorse it, adding that everything I have done since the Mid-Staff's inquiry suggests that without transparency, bad things happen. And therefore, I would encourage everyone, including the CQC, to continue with this sort of exercise. But a specific question about our insight, which of course I welcome, really one is about feedback on, well, two things. One is feedback from care home providers and others about how helpful or otherwise the guidance they have received in relation to public health issues. Well, inevitably, some of that has changed sometimes quite rapidly, but it seems to me that we have access to, through our ECF and other ways, to providers about how helpful or otherwise the guidance is and whether there's clarification required. That's the first question. And the second one is whether we, and I think, Kate, you alluded to this, whether there's more we could do in relation to getting feedback from both staff, but perhaps most importantly service users in the social care sector. And why that's useful, it seems to me, apart from the obvious reasons, is that Healthwatch, by way of example, has had some feedback that domiciliary service users have been afraid to continue to use services because of a lack of PPE from available to the people coming to their homes. And there's the same thing, actually, we've had feedback about people going for non-COVID related treatment. They're afraid to do so because of a feeling that the staff in those areas have not been using PPE. And I just wonder whether those sort of issues could be surfaced by us through some of the contacts that we have, which perhaps others would find more difficult.
Do you want to start, Kate, and then we may widen it?
Sorry, right. Thank you, Robert. So providers' view of guidance. I think there was a really quick succession of guidance that was put out that that changed along with the science. So I think if you were a busy registered manager in the thick of it, it probably felt pretty tough to keep on top of the guidance. What we have done is we have, in our conversations with registered managers, talked them through, supported them, answered questions, signposted them. But I think providers would absolutely say that there was a succession of guidance that changed along with the science, but was pretty tricky to keep up to speed with. With regard to feedback on staff, so I was going to say this earlier, but I didn't know. So I was talking to an inspector called Lucy. So Lucy is an inspector in Surrey East. She's been working with some learning disability services. And what Lucy was saying was, prior to the emergency support framework joining, Lucy was regularly joining Zoom meetings with staff and with managers across the service to observe interactions, to hear how the issues were, and also to remind them that she was there and that they could have direct conversations with her. She's planning on having increasing conversations directly with staff virtually to find out how they are coping with COVID and what the emerging issues are. And then with regard to domiciliary care, home care, this will come up under the next item when Stuart Dean joins us to talk about market oversight issues. But home care providers have absolutely said that they have seen a reduction in people choosing not to receive home care during COVID, for a variety of reasons. The number one reason cited is a fear that the care worker, would be bringing potential infection into the home, as would any person regularly coming into someone's home and then going into another person's home, etc. But Stuart will talk to that when he joins us shortly.
Can I just answer the guidance point? So, Robert, it's a really important point. One of the things we try to do is to embed some of our colleagues in partner organisations to get a grip on the guidance. So, for example, we've lent one of our people to NHS England. So when we're talking a bit about the guidance, particularly for domiciliary care, we have a consistent view. We're not presenting disparate views. The other thing that we've done in response to the feedback from providers is to create a page on our website where providers can go for information about all the guidance that relates to them. So to bring other organisations' guidance into one place. We're working with DHSE around a sort of a summary of that guidance, so that again we can create a one view. But I think the point is well made. I think a lot has changed in a relatively short period of time. So by embedding people in other organisations and by creating one view in one place, we hope to minimise, but no doubt the confusion that exists out there. I think one of the things, just going back to what we said about going forward, I think going forward there's a real recognition that you can't just displace guidance in different settings and assume people will respond in the same way. And I think making sure that we're using one of the benefits of where we are now. People are using our tool to reach tens of thousands of registered managers to test guidance before it lands. It's been a painful process, but getting people into the idea of testing things before you put them out, and don't assume that the same message will land in a different sector, has been something that I think is a positive out of this. Certainly our colleagues now feel more assured that they can send information to us, we can use that testing process, and we can get better information. But there's a long way to go, and I think there's a lot more we can learn.
Peter, can I just say something in response to Robert?
Yeah, please. Yeah.
So, Robert, I think you're entirely right. People with non-COVID conditions who need to go into hospital or to seek care need to be confident they aren't at risk of infection with COVID by seeking that care. And we need to do everything possible to make sure that they are confident. Providers need to make sure they've got really good infection control arrangements in place, which is why we are focusing on that at the moment. I think, come back to the transparency theme, I think it'd be really good if any information available around cross-infection in hospitals or other settings was made freely available, so that people had trust that this was being monitored and dealt with.
Thanks, Ted. So with immaculate timing, Stuart's just joined us. So if people are happy, let's invite Stuart just to give us a quick sort of insight into the financial implications of COVID on the care sector as seen through the prism of the market oversight members. Stuart, welcome. You'll have to come off mute, Stuart.
Always helps. So, in the update that I provided to board in March this year, I said that the risk that C19 posed to the sector was substantial. Indeed, the types of challenges that C19 is presenting mean that they will be felt by even the strongest of businesses to the extent that they remain unfunded. To effectively understand emerging risks, market oversight has continued to engage extensively with the providers captured by the scheme and then feed this output into cross-government thinking and discussions. If we turn to care homes, there was a typical occupancy decline of over 6% in April and a current expectation of a further occupancy decline of over 10% through to June. And that's a result of a continued mismatch between the number of deaths and admissions. The number of deaths, however, is now consistently reducing, albeit there is variability, with some providers now reporting that it has returned to seasonal norms. Admissions, on the other hand, remain depressed as the private pay market has collapsed and both NHS and local authority referrals remain lower than what would normally be expected for this time of year. If the level of occupancy reduction were to occur, so this is the forecast continued level of occupancy reduction were to occur, then the impact on profitability would be profound, as this is before factoring in the impact of increased costs associated with PPE and staffing. Current sort of market expectations are that on a best case basis, the occupancy recovery period is likely to be over 2 years. Turning to home care, the volume of weekly hours has typically reduced by over 7% across the market oversight portfolio. That's driven by C19 infection risk concerns, where individual service users are declining visits to try and minimise the risk of C19 infection entering their own home. Families being able to resume or increase their caring responsibilities and reduce commissioning activity by sort of local authorities and to a certain extent the NHS. Given that home care operators frequently have low profit margins of between 3 to 5%, this reduction in weekly hours adversely impacts profitability. And again, this is before the impact of increased costs associated with PPE and staffing are considered. In terms of increased costs, the PPE expenditure is driven by both increased usage as well as substantially higher individual unit prices. These have frequently been reported as over 3 times higher than the price that would ordinarily be paid. Higher staff costs have been driven by increased statutory sick pay eligibility, higher absenteeism, self-isolation and shielding. Absenteeism typically peaked at or near 20%, and whilst it has reduced, it still remains elevated at circa 10%. Market oversight provider responses that were received up until the first week of May suggested that some form of C19 support had been offered by typically 60% of local authorities. However, the level of support and therefore adequacy was variable, averaging at circa a 7% uplift. The same responses suggested that there had been much less support from clinical commissioning groups, where typically less than 10% had made an offer. The provider response to the uncertainty that the C19 pandemic has presented has understandably been to preserve and indeed accumulate cash. This has frequently been seeking additional commissioner support, not making scheduled pay-as-you-earn and national insurance payments to Her Majesty's Revenue and Customs, as well as securing wider stakeholder support from owners, lenders and landlords as appropriate. To the extent that additional commissioner support is either inadequate to maintain short-term liquidity or is insufficient to at least preserve existing profit margins, then capacity can be expected to leave the sector with the consequential impact of increased uncertainty for people using services, additional costs for local authorities, and a knock-on impact to the NHS. Are there any questions?
So, Stuart, just picking up that last bit that you were saying, it seems to me that the situation doesn't end when COVID ends, whenever that is, because the taxes that have been deferred, the loans that have been taken out, whatever, have still got to be met. So the already fragile finances of the sector are even more fragile, and that extends into the future. Is that a fair summary?
That's absolutely correct. Whilst companies have generally successfully been able to accumulate the cash, the ways that they've been able to do that have been on a short-term basis. And whilst it's important on the one hand to ensure that companies have the liquidity here and now, what the teams are also focusing on is how that's likely to unwind, and what does that actually mean for the recovery phase when this short-term support may actually start to unwind. The key thing is that it provides a window for it provides a window for additional support to come into the sector. But this is my point around where if the level of that support isn't adequate to sort of preserve liquidity or maintain existing margins, then we can reasonably expect capacity to leave the sector.
Thank you. Any other questions or comments for Stuart?
If I may, Peter.
Yes, John.
Thank you very much for that. Do you have a sense of what that capacity reduction might look like, should it come to fruition?
We've done some sort of provisional analysis based on a broadly a 10%. So if I take a step back, we've done some analysis of the market oversight providers that equate to 10% of the CQC registered beds. I've sort of talked to the average occupancy decline in April being circa 7%, and the forecast occupancy decline across those providers being broadly a further 10%. If you roll that sort of forward and calculate the occupancy reduction, and you then assume that operators flex their capacity to restore equilibrium, which is broadly considered to be at or around 80%, then it would suggest that there is vulnerability around 50,000 beds there or thereabouts. I would point out, however, that that is based on a number of assumptions from the current information that has been provided by providers, and that is a changing landscape.
Thank you.
Sorry, John, I was just going to say it's also important just to keep reminding ourselves, Stuart, this is based on the market oversight providers.
Absolutely.
So you may get different responses from the smaller providers. No idea whether that would, in which direction that would be, but I just think we have to keep reminding ourselves that this is based on the larger providers. John, you were going to ask another question.
And it is only, I sort of emphasise, it only equates to a broadly 10% sample size of CQC registered beds.
Yeah. John?
No, I was just thanking him.
Oh, right. Sorry, I thought you wanted to come back with something. Anybody else that want to ask Stuart or make a comment? Stuart, I think it's really helpful. Thank you very much for your time. Thank the team for the work they're doing. And obviously, along with many other things where, we need to be really closely watching what's going on. This is an important area. So thank you. Colleagues, we said we'd have a 10-minute break at this moment. Is that a good idea? Allow John to go and feed his sheep or whatever they need. And should we start again at midday? Is that okay? Perfect. Thank you all.
Sorry about that.
It's good, John. Good to know you're in the country. Right, to continue then, I think we now move on, Ian, to the executive team report, please.
Thank you very much, Peter. Thank you. I think I just really, we've, as always, for the last couple of meetings, our work has been very much dominated by work on COVID-19, as you would expect. We are going to continue with the high tempo of management meetings with these regular gold and silver command decision-making structure that we put in place right at the start, and that's enabled us to move very rapidly. It's enabled us to make some changes in policy and approach quite quickly. I am, however, hoping to start to scale this back a little by the end of this calendar month, and I'm hoping the next time we meet, I'll be able to report that we're in on a more sustainable footing. But this is certainly, I don't expect to be back to normal in a month, but I think there is something about getting to a sustainable footing. Many colleagues have been working sort of continuously now for a couple of months, and we need to make a conscious decision to step that back, and to make sure that we can continue to operate at an enhanced tempo, but over a longer period of time. I think it also kind of it's worth just noting that we need to be able to change and make course corrections as we go along this. In the event there's a second peak or there's changes to Public Health England or government advice more broadly, then we need to accelerate or decelerate our activity accordingly. So as we said right at the start, our activity and our leadership activity has always been tried to be in lockstep with the advice that we're getting from government and from Public Health England, and that will continue to be the case. I can see no obvious reason for us to diverge significantly from that. There is in my report a section on testing, and I am going to unashamedly repeat what I think a number of people have said in the earlier section around testing. So as I reported last time, we were able to offer short-term help to book social care staff into drive-in testing, and help care homes order test kits for residents. We did this using our technology and our people in our NCSC group. We have now stopped all of this work. I'm going to say that again really clearly, so there's no ambiguity for any media who are following this meeting. We have now stopped all of this work at the beginning of last week, as the government have launched 2 portals to enable direct booking, one for staff and one for residents testing. I'm conscious there has been some confusion in the media about our role, but for absolute clarity, we created a temporary digital booking service supported by our National Customer Service Centre. We did not lead the process. We did not handle the results in any way at any time during that process, and nor did we provide any clinical leadership on any aspect of the testing process. And I appreciate I am slightly flogging this point, but I am doing that very deliberately because during the last week, I think we have had a number of questions, particularly from parliamentarians actually, who have had questions from their constituents. So I have written to a number of parliamentarians, both in government and in the opposition and backbench MPs, who've been wondering what we've been doing and where the role that we've played in delivering the testing program has been. And I've clarified in some detail exactly what we have and indeed have not been engaged in. But I think it's just really important just to emphasise that we are no longer involved in any aspect of testing. We are aware, though, as Chris and Kate in particular have both said, is that we are still getting inbound calls from providers. We're still getting conversations with providers when we call them, and they are asking us about what we're doing about testing and asking us to help them with that. So again, we'll reflect the feedback we get in the Insight report, as Chris said, but we're not going to be physically hands-on with testing. Of course, we own the address book for social care, and if we are approached again by the government team who are running testing, then of course we'll have sensible conversations to help out where that makes sense, and more importantly, where we feel that we can help without compromising our core regulatory role, which has always been at the heart of what we're doing. So I think in the next period, we are going to continue to roll out the ESF in the way that we described earlier on in the agenda, and we'll be reporting on the results in public through our Insight report every 2 weeks. And as others have said, I would expect that this will lead to more on-site activity, more of our people going out, crossing thresholds to one level or another, and in a small number of cases, it may very well lead to full inspections or partial inspections, and may in extremis lead to enforcement activity. That will be a small number of cases, but I think the public should be assured that we are very much on the pitch and very much active, albeit slightly limited by the COVID position at the moment, but we are very much in the game in terms of regulation. So I'm going to pause there, Peter, and hand over to Kate for the next section. Thank you.
Thanks, Ian. Kate.
Thank you. So for the adult social care update, a huge amount has already been covered in board. So just to recap, as Ian said, we temporarily provided some support around testing. We're not doing that now. We spent 6 weeks of having structured conversations with providers while we worked with our digital team and our policy team to design the emergency support framework that went live in adult social care 2 weeks ago. At the start of COVID, we developed our ability to have information provided from home care providers on a daily basis. That is up and running now, and the work over last month has been assuring that we're putting together the different data that comes from the capacity tracker that sits with Public Health England, that sits with us around home care, to ensure that there is a single view of what's going on in social care as a result of COVID, so that people are informed, but also so that data can be used to drive action either nationally or at local or regional levels. In addition to that, we've been working with Think Local Act Personal and local government to understand the potential impact around Care Act easements. So we are working collaboratively to focus some of our efforts to understand what it means for residents of those parts of the country where Care Act easements have been switched on. And you've just heard from Stuart Dean about the enhanced work we've been doing around market oversight and providers that fall within that remit. So that's what we've done on COVID. Peter, do you want me to mention the two other brief bits in the adult social care update? So I just want to briefly talk about restraint, seclusion and segregation. So board will be very familiar with the fact that a year ago we published our interim report into restraint, seclusion and segregation that was predominantly focused on the findings from mental health inpatient units, and board is also well aware that we then moved on to phase 2, which was looking at restraint, seclusion and segregation in social care settings and settings such as secure children's homes. throughout all of this, so we published our findings last year with the headlines of, in the absence of having a consistent community offer, people often end up a long way away from the family home, not having the best outcomes, with staff who don't necessarily have the right training or skills in an environment that increases distress behaviour, and without an unrelenting focus on getting those people back to their normal home, their normal place of residence. We've worked really closely with an expert group of family members and people with lived experience to design the recommendations that will be in the final report, and we were ready to publish, but the point we were going to publish was in the middle of COVID. So in conversations with those stakeholders, with those family groups and people with lived experience who have really helped drive this with us, we made the collective decision that actually we wanted to wait for COVID to subside so that this report gets the impact that it deserves, because it's just the most important agenda. So we anticipate cranking this back up again towards the end of summer and autumn, and making sure that it lands with actions that are going to lead to delivery, because families, as some of you who might have listened to the Joint Committee on Human Rights on Monday, we had two amazing mums describe their experiences of their adult children who are in assessment and treatment units. For families, there has been report after report since about 2007, and there's a frustration that there hasn't been enough traction, there hasn't been enough movement on this agenda. So we are really keen, when our restraint, seclusion and segregation final report arrives, it arrives with clear, deliverable recommendations, with the right people who need to deliver those owning it and ready to go. So it's not been forgotten. In some ways, it's the complete reverse. It needs to be published when it gets the action that's needed on the back of it. And then just my final piece that I can go into more detail if the board wants. In your pack, you've got a detailed breakdown of the work we're doing around closed cultures. So there's a link between the previous item around restraint, seclusion and segregation and this. So we've got a single piece of work now that has brought together the David Noble recommendations and the Professor Glynis Murphy Part 1 recommendations into a single programme, to ensure that we've got really good oversight about what's happening with every aspect of that work. What you'll see in your board report is there is a summary of what's been delivered, there's a summary of what's in train for this quarter, and then there's a forward look to what needs to happen from July onwards. There's been some really good progress. So our supporting information for inspectors has been really well received, and was enabling inspectors to work differently when they were identifying closed cultures prior to inspecting and tailoring their approach prior to COVID. There are other areas that we need to get more pace on, and we've got a plan to do so. It's also really important with this piece of work that we, as well as saying when we've completed something, we have that assurance. So, okay, we've completed it. What does that mean for people who receive services, for providers, for our staff? So you will note, as we come back to a future board on this item, there will be an increasing focus on each of those elements on the kind of so what question. Okay, you've done that. What has been the improved outcomes for people as a result of it? So a load of information in your packs about closed cultures, and really happy to take questions after if there are any from the group.
So let's just pause there, Kate, and just see whether anybody does want to ask questions or make comments. I mean, I thought the annex to the pack was really, really good and really helpful. So thanks very much for that.
Sorry, yeah,
Liz.
Yes, thanks. Yes, so I agree absolutely with the decision to postpone the final report on restraint, segregation, seclusion till the right time for it to have the greatest impact. I just wondered in the meantime whether we have ways of monitoring and keeping a handle on what's happening in relation to restraint, seclusion, segregation. Are we able to identify if there are concerns in this area now that we need to act on? And this may relate to the earlier discussion we were having about what was happening, for example, in mental health settings and other such environments.
Can I comment about that? Is that all right, Peter?
Yes.
So to answer your question there, Liz, I was going to come to this in any case after Kate's explanation there. I think we're very conscious that the solution for these people cared for at the moment in assessment and treatment units for learning disabilities and autism is a different model of care, and our report is going to say that forcibly, and so many other reports have said that. We've got to make this really count for those individuals. But in the meantime, we have to deal with the current risk. And as the prevalence of COVID-19 is diminishing, then I think it opens up the opportunity for us to revisit these services. And we are already doing that. And Kevin made that clear at the Select Committee on Monday. So I think it's very important that we are not forgetting about the current risk in these services, and we will be monitoring all the indices we get. And you're talking about the data on restraint and seclusion. We will monitor that, but also, of course, we rely heavily on staff and family members speaking up about care, and we a lot of that will drive our inspection activity going forward. So we will be monitoring those services very carefully, and we'll be inspecting and we'll be taking action. And remember that we know these services very well because we've inspected them, we've reported on them, we know where the high-risk services are, and we will be looking at those very carefully going forward.
And can I just, one quick follow-up? Does that apply also to psychiatric settings? So you've talked about people with learning disabilities and autistic people, rightly, and we've had a big push on visiting all of those. But I just wondered about, all levels of psychiatric settings as well, from high secure to kind of regular inpatient.
Indeed, it does. I was narrowing down on that, but actually it would apply to all these high risk environments. Indeed, yes.
Thank you.
Thanks. Ted, you've got the floor. Do you want to move on to your report?
Okay, thank you for that. So there's detail about the mental health report and infection control in the written report. I won't go through that again because we've touched on it already. I just want to make some background points. I think a month ago at the board, I praised the acute sector for the way it had responded to the COVID pandemic. And increase intensive care capacity, and I think they did do excellent work there. But of course now the incidence of COVID is beginning to diminish, and we've passed the peak. The focus is very much on restoring the services for people whose primary need is not COVID but have got other medical needs, and I think that is a real priority going forward. And we've been talking to providers across England about how they are approaching that and what are the obstacles for them. I've already touched on infection control as one of the key elements. We touched on that earlier on. I won't stress that again, but we have a very strong focus on infection control standards going forward because that is a key enabler. There are other factors that will affect this, and providers have told us of shortages of some key anaesthetic drugs, for instance, which need to be addressed nationally, but also shortage in some areas of key equipment that's been driven by the COVID pandemic, and those are being dealt with. I think for me a real concern, and I've been talking to staff from emergency departments all over the country this week about this, there is a real concern. The board will know that attendance in emergency departments has diminished quite significantly during the COVID epidemic. That is slowly beginning to increase now, which is good because people who need care are accessing it. But the emergency departments are now working in a very different environment, an environment at which patients with COVID are mixing with patients who do not have COVID, and they need to protect patients from cross-infection. That means they have to control the front door of the hospital very carefully and make sure that patients who are infectious are not mixing with patients who are non-infectious. They need to cohort their patients once they get into the hospital. And of course, once patients are admitted into inpatient wards, they need to be protected from cross-infection. And all the steps that are being taken to do that will reduce the capacity of some acute hospitals quite significantly. And that is going to affect the ability of emergency departments to function going forward in terms of their capacity and flow. And at the moment, that's not a big issue because, of course, the number of patients have diminished. But as the number of patients increases, and particularly as we go into next winter, when, I'm sure COVID will still be around, but there'll be lots of other winter viruses as well. Then these services have got to deal with the ordinary winter pressures plus whatever else COVID adds to that. And I think there's a real worry going forward. Do we have the plans in place for that? And we are working with the system to understand what plans they're putting in place and trying to share good practice to make sure the system is as well prepared as possible for next winter. And I think that's an important priority going forward. We're also, as I say, been looking at those closed cultures, and they are a priority going forward. But we're also working with the system to understand their priorities around other patients who need care, for instance, patients who've got cancer care or seeking elective care, to make sure they are prioritised appropriately and people who need care are getting the right care at the right time with the right level of priority, because there is clearly a backlog, and that backlog needs to be cleared in a way that puts patients' needs first.
So, Ted, you're rightly talking about the need for people with long-term conditions and other needs to be able to access care, and then you were talking about the system. It seems to me that the system here is both the acute hospital, but it is also primary care as well, isn't it? And it's getting the two working really well together.
I think that's right, Peter, and Rosie no doubt will have comments on this as well when we hand to her. But I should say there have been some really positive signs during the COVID epidemic about different parts of the system working well together. Not universally, and that there are still clearly barriers between different parts of the system, but actually I think there's been really strong forward movement. And I chair a regular meeting of secondary care and primary care clinicians discussing their approaches to managing COVID-19, and it is really good to see the very close integration between different parts of the service at the moment. So I think there's a real positive we need to build on, and so many people are saying that we have achieved really positive things in COVID-19 we need to build on, but equally I think it has demonstrated some of the problems in the system which we've been talking about for a while in terms of integration and collaborative working.
Thank you. Does anybody have any questions for Ted, or shall we move on to Rosie?
Just a quick one, if I may.
John, please.
In terms of sharing good practice and learning from elsewhere, I've heard from colleagues in Denmark and Sweden that they are mandatorily requiring people to go through a triage process rather than just roll up at A&E. Are there any tests of that working in this country?
There are plans being put in to do that. So there's a telephone triage service, so people are triaged before they go to A&E, and where possible they're triaged away from A&E. But if they're possibly COVID positive, or if they've got symptoms of COVID, they can be triaged to an area where they're not going to cross-infect other patients. There are trials of that going on, yes, John. And we'll certainly want to understand good practice and share it across the system.
Thanks.
Yes, please.
Mark.
Thanks, Chairman. Ted, could I just try and pull together a couple of themes that you've been referring to in terms of us transitioning back to our core purpose, in terms of hospitals restoring services, and perhaps a little bit of the new normal going forward. For instance, I've heard recently that hospital-based geriatricians want to extend their role in the care sector by using tools in provider premises such as virtual wards, telecare, remote MDT, and being involved with primary care and community geriatricians in case conferences. If that is indeed happening, will we need to have to look at our inspection model in hospitals going forward?
Mark, I think there is some really positive work going on around that. There was work going on before COVID in terms of that integrated care of the frail elderly. I think the COVID epidemic has given that more momentum, and I think there's some really positive work going on in terms of outreach from acute care into the community so that people get continuous care, and they're only admitted to acute care when they're going to benefit from it rather than just as a default position. So yes, absolutely. And when we look at the care of people with long-term conditions or the frail elderly, I do think we need to think of a different inspection model, because we need to look at the care as it's received by the patient rather than the care through the eyes of how it's provided by the provider. And we need to challenge providers to provide that truly integrated care. And I think there's real opportunities there. Of course, that is exactly what we're talking about in local system reviews and beyond barriers. But again, this has given new impetus to that. And I think there's a real challenge coming out of the COVID-19 epidemic. How do we move our inspection approach forward to take into account the fact that people should be getting, and I hope will be getting, more integrated care?
Yeah, I totally agree, Ted. Your point about system reviews, we highlighted that, but I just feel that this has been a real push towards that happening.
Yeah, well, I'll hand over to you a moment, Rosie. I think it's been a push in some ways, but equally it has exposed the problem in others. Rosie, over to you.
So I was just going to add to that, because I'm really, really keen that we use this as an opportunity to understand what has been happening in systems around the response to COVID. And actually, I've got a proposal that's coming to the executive team later today or early tomorrow around how we could do some rapid work to really understand the system response to COVID. I think we've seen some great practice, as I said earlier, of people working in a different way. We've certainly seen different use of technology in terms of systems working together and all sorts of innovations. But I think we've also seen that it has exposed some significant issues. And I think we need to understand how, as a regulator, we can support the system, particularly before any further peak or any kind of winter pressures, what we can do in a rapid way to be able to support system working so that things improve in a rapid time scale. So, Peter, I don't know if you want, sorry, I rather came in on the integrated care. Do you want me to carry on with the rest of my...
Yeah, carry on. Great. Thank you.
Okay. So the next thing I just wanted to mention was around private dentists. You may have seen a lot in the media over the last week or so about what's happening in private dentistry, and some comments in the media about what we are and what we are not doing in that sector. And I just want to absolutely lay it out what is our position and what is our role. So we've been working with key stakeholders such as the Chief Dental Officer and looking at the guidance that they've been producing over the last few weeks, and trying to support the public health messages around the Chief Dental Officer's guidance. But essentially, whether a dental service decides to open is a decision that the provider needs to take, and we cannot require providers of dental care services to close unless there's very clear breach of any of our regulations. We have been asking dental providers to take due consideration of the CDO communications, and we are assessing the extent to which these dental providers are actually providing safe care in line with the guidance that Public Health England and the CDO are putting out. And I think the things that Ted has been talking about earlier around infection prevention control are equally important in any of the settings that we regulate, and so making sure that people aren't at risk of transmission, particularly in dental settings where there is aerosol generating procedures. We need to make sure that guidance is being followed, and people do have the correct equipment and a correct way of managing patients. So I just wanted to clarify that we're sending out a further communication out to dental providers today, just to clarify our position and to also talk about the work we're doing with the emergency support framework, which we are aiming to roll out in dental providers in the coming weeks. So that's dentists. In general practice, we started the rollout of the emergency support framework on Monday. That seems to be going very well so far. We have noticed, as everyone will have seen, a very significant transformation in primary care to a much more remote access model at the moment. And I think the sandboxing work we did earlier in, last year around digital triage has put us in a really good position to understand what does safe care look like when people are using digital triage tools and when people are remote consulting. And that's enabled us to look at the emergency support framework as well and check that whilst people are using video consultations and more remote monitoring, that's done in a safe way. I'm really keen, as everyone else is on the call, to look at how routine care gets back to normal, back to being delivered. I think back to normal is probably the wrong term. And actually we are seeing some really good innovation, as I mentioned earlier, in primary care about how people continuing to have their long-term conditions being managed, how some GPs are being very proactive in following up people who are vulnerable, having good discussions around advanced care planning, all the things that we know lead to really good quality care. We're also seeing some really good examples of how innovation is being used for some of the more routine things like baby vaccinations, which clearly are really important. What we don't want on top of COVID is an outbreak of measles or an outbreak of other diseases because people haven't been able to access their care. I think it is going to be really important for us to understand longer term what the implications of people not accessing the screening and not accessing some of that long-term conditions care is going to be, and we're working through with other bodies how we understand that in more detail. Just then to mention, the final thing to mention with about GPs is we are having a series of calls with all the CCGs this week just to talk about the emergency support framework, but also Kate's team are joining me on those calls because I think there is a real opportunity to look at the support into care homes and the support that clinical teams in CCGs are able to give them, and so we're doing a kind of double act those calls, which are going down well at the moment. The final thing I just wanted to mention is about antibody testing in independent health. So we've been putting out very clear guidance to our independent health providers around antibody testing, and up to quite recently there hasn't been any tests that have been approved, and we've been following the advice of people like John Newton with this. Some of the providers providing antibody testing are in our scope of regulation. There's some that aren't in our scope of regulation, but we are encouraging all providers to look at the guidance that we're putting out. I think the situation is now changing with the new antibody tests, which are more effective, but I think it's really important that providers counsel their patients properly before these are used and don't infer that these will say whether you're immune to COVID or not, because at the moment, whilst you might be positive for your antibody test, what I'm hearing is that doesn't necessarily infer that you are immune to COVID. So I think it's really important that we keep following up those messages and make sure that providers that are using those antibody tests are doing them in a way that's safe for patients. And the final sector, sorry, I want to just mention is 111 services. 111 services have been under huge pressure. There's been enormous changes in terms of how they've been running. They've been, when we look at the other services that wrap around that, such as the COVID clinical advice services and other related urgent care services, they have been through a lot of change. Our teams are working very hard to understand what those changes look like, understand the pressure that those services are under, and make sure that we understand how we can regulate those going forward, and work is going on with the ESF in that.
Thanks, Rosie. It's interesting. Somebody was saying earlier that it's only 8 weeks since we've been in lockdown. Feels like a lifetime. But and my understanding is that and effectively a pause and a lot of, if I can call it, routine work for people with long-term conditions, but also for dentists and all kinds of things. A pause for 8 weeks may have some damage, but the damage gets significantly worse the longer this goes on. So it does seem to me there is a real priority for services to be really, all services to be really focusing on how they can get back up to speed, obviously safely, and obviously there will be capacity issues, but that seems to me to be something that across health, I mean, social care has never stopped, but across health, we really need to be focusing on, or getting our providers to focus on.
Peter, can I ask Rosie a question?
Yes, Robert, please.
Just about the last thing, you were talking about you were talking about testing. Do we regulate the providers who are selling antibody tests to the public? I mean, it's not just they provide equipment for that test and analyse it. Some of them are providing online consultations with doctors, and in fact, I think that's what they do. So, are we regulating those? Because I imagine that these are new sources of service, as it were.
So it's a mixed picture, Robert. As I understand it, we regulate some of them. So if they're providing online consultations and if they're providing treatment or what we consider to be in the TDDI category, then we do regulate them. Some of the people that are just selling tests don't fall into our scope of our regulation, as they're only purely diagnostic. And I think we're continuing to work through this and test out what is in our scope of regulation and what's not. But we are working closely with the MHRA where they don't fall in scope of our regulation, to make sure that we're doing all we can to protect people from potential harm from any tests that aren't going to be accurate.
The reason I ask is that, I mean, that some of these sellers, in fact all of them, make claims with regard to the absence of false positives or negatives, whatever it is, and I, as a member of the public, have no means of knowing whether what they're saying is correct or not. And I just wonder, is anyone actually monitoring that to see whether what they're saying is accurate?
Yes, it is something we're working with the MHRA around, but there have been a variety of up to now where there's been all sorts of antibody tests which haven't been approved and haven't been felt to be very accurate. We have had a clear message that they shouldn't be used because then they're not accurate. As I said, the situation has now changed with these more recent tests which are being rolled out in the NHS that are felt to be more accurate. But it is something we're continually working on.
Robert, I'm not sure whether you turned your camera off deliberately or it's just turned off, but if it wasn't a deliberate action, you might want to turn it back on so we can see whether your beard's grown since the start of the meeting or not.
Almost certainly, but interestingly, when my camera is on, the sign on my screen says it's off, which is slightly confusing.
I can't see you anyway. I can hear you, which is probably the more important thing. Seriously, are there any other questions for Ted or Rosie? In which case, sorry, go on.
And then we need to move on to Kirsty, and I know Kirsty's been supported by Kieran Prashar, who's just joined the meeting. Thanks, Peter.
Thanks, Ian. Thanks, Kirsty.
Hi, thank you. Just two updates from me. So as Kieran's just joined, we'll move on to the people report. There is a bit more of an update in the change report on people, but Kieran has joined just to talk about some of our cultural work. So Kieran, do you want to take the floor?
Yeah, no problem. Can everybody hear me? Yeah, great.
Yep, good. Go.
Okay, so I've been asked to kind of come and give a bit of an update on the culture work that we have been doing. So the culture and values is a key element of the people plan that we have spoken with and shared with the board previously. And the aim of this strand of work is about embedding and involving our culture and behaviours to deliver our purpose and our strategy now and in the future. And part of this has been about developing a baseline view of our current culture using an inquiry approach. And the inquiry approach is something that has been done across government, led by the Cabinet Office. And what this means is working with colleagues across the organisation to observe, notice and highlight key aspects of the way that we work, and these are often those aspects that are below the surface, things that become habit and nature about how we work. And a core premise of the inquiry approach is that by making culture more visible, we are able to take action to change behaviours or enhance behaviours. So the culture inquiry was due to start in March through a series of face-to-face regional workshops, which were aligned with wider work on transformation and our future strategy development. However, as a result of COVID, this work was paused while we all focused on more immediate priorities. But I would say that during this time, we've seen the organisation and our people adapt to new approaches, different ways of working and different behaviours. And it presents with us an opportunity really to capture the positive learning from our response to the pandemic, and crucially, what are those behaviours that we would want to retain for the future. So we've redesigned the inquiry so that we are able to deliver this virtually, and we'll be running a series of online workshops for colleagues to take part in over June and July. And the outputs of these workshops will continue to inform the development of the people plan, but also critically the transforming our organisation programme and all of our kind of future strategy development work. And we're also working really closely with our evaluation team to make sure that we're capturing and sharing that learning from our COVID-19 response. I hope that's helpful, and I'm happy to take kind of any questions.
Very helpful, Kieran. Thank you, and great work. Questions? Comments?
Chairman. Kieran, thanks very much indeed for that update, and good to hear that this programme is continuing. You make the point about capturing learnings from COVID into our organisation, and culture for me is acquired behaviours, and clearly we're acquiring new behaviours through this process. I just wonder whether we are actually going to capture before and after, rather than just coming up with the after.
Yeah, it's a really good question, because I think it is quite difficult when we are starting to use the inquiry approach to understand how we work now. I think there will be that sense of blurring between kind of which elements of those behaviours are things that have happened from before and things that are new. But we have adapted the workshop where we are trying to get people to focus on what's changed in the last couple of months. So really trying to hone in on those bits that are new behaviours or adapted behaviours. The other bit of supplementary kind of insight and evidence is through the Pulse survey. We're asking a free text question, specifically asking people to identify those positive things, positive changes that have happened as a result of our response to COVID that we would want to retain for the future. So hopefully that gives us some more specific stuff around what's changed recently. I hope that helps.
Thank you, it does. I look forward to hearing of the results.
It's Liz here. Could I just ask a question? I mean, it's great that the workshops are happening virtually so that colleagues can be really involved in this process. I just wondered how people will be involved in drawing the conclusions, if you like, because culture is notoriously subject to different perspectives. And I just wondered how the process is going to pan out in the next stages, so that you can kind of draw out what needs to happen to make the changes as you were mentioning.
Yeah, so there's probably two parts to that. I think one part of it is that through the workshops themselves, we are encouraging those people that take part in the workshops to take the information or the insight that they've gathered as a mini group and start taking action on it almost immediately. And I think that speaks to our kind of view of culture as something that is dynamic and constantly changing. So that doesn't require any analysis or evaluation, but actually by revealing some of those ways of working, what might we all do as an individual, as a group, to change things. So there's something quite localized and taking personal accountability for culture change in terms of individual behaviors. At the kind of macro level, I think there is still some work for us to understand about how we merge both our analysis of the culture inquiry workshop along with any other bits of insight that we're gathering through the evaluation work and recovery work as well, so that we can develop a kind of coherent picture of what it tells us about today and what we need to shift for the future. But crucially, I think the outputs of the culture inquiry work are not really about trying to say whether things are good or whether they are bad. They're simply about presenting a picture of how things are at the moment. And I think it then becomes I think you're right about involving other people and the wider organisation in almost a team-based conversation around what do we do with this information now that we have it, and what are the aspects of culture that we really want to kind of highlight for the future based on what we've learned around our evaluation of the COVID response.
Thanks, Kim. Helpful.
Great.
And Kieran and Kirsty, you'll be back with the board to the board as the work develops, and with some of the findings, which are sort of the next stage. So this is not the last we're going to see of you by any means. I think. I hope not, anyway, because it's really good stuff and really important.
That's right, Peter. And we did say as well that we would run a cultural inquiry workshop for the board as well,
yes.
in the not too distant future too.
Yeah, that will be good. Kieran, thank you very much.
Thank
indeed.
you.
Kirsty, do you want to go back? I think probably.
Yes, please. It's just to the report and accounts and an update on that. So I'll just pass back to Chris. He'll just just give you a quick update on where we are with that.
Thanks, Kirsty. Yeah, just a quick update on your report and accounts for 1920, as you mentioned. So our external auditors, NAO, have notified us that COVID-19 has impacted the timescales by which local government pension schemes and their auditors can provide valuation and assurance on our pension assets. We anticipate the delay to laying our accounts before Parliament to September. We usually aim to lay around July time, so it's a position that's out of control, both CQC and NAO, but one that's manageable.
Okay, but the rest of the accounts, we
rest of the accounts are going to timetable and progressing nicely.
Yeah, great. Okay, anything else on the accounts? If not, Kirsty, is there anything else you want?
No, nothing from me. The rest will pick up in the change update.
Okay.
And then Peter, if we could then move on to Chris. If we could then move on to Chris, thank you.
Yep.
Sure. Just a quick summary of recent activities. You'll be aware that we've been responding to a number of requests from MPs in relation to our activities under COVID. This will continue alongside the parliamentary questions that we've been responding to. We've also had a number of meetings with the shadow health team, and we've set up meetings with the stakeholders in the relevant committees. We've been updating all providers. We talked about it earlier on in this meeting, but we've been updating all stakeholders on our first COVID Insight report. And from the feedback we've already had, it was only launched yesterday evening. There's been some very positive feedback from a range of stakeholders, and the fact that we've put the information into the public domain. We will be giving, or we have given evidence rather, to the Human Rights Committee on the implications of COVID-19 on Monday. And again, I think that's we've got some positive response to what we have been able to do, and we've got some clear actions that we're taking forward in response to that. And we've been responding to an NAO study on the readiness of the NHS and social care for the COVID peak. We've touched on the ESF already, but all I wanted to say that we've, as colleagues will be aware, we've been engaging both providers and public groups to try and describe what the ESF is and what it isn't, how it works alongside our other elements of regulatory activity, and the key element of that is how we get the voice of people who use services into those conversations. And with that in mind, we are we'll be launching our next peak of Give Feedback on Care, working with colleagues in Health Watch and other groups that represent people who use services. This time we're also trying to target people who work in health and care organisations to make sure we hear their views. And indeed, we've already seen a significant rise in information coming from both service users and also from people who work in services, and that information has already triggered a number of responsive inspections. So we want to try and encourage that still further so we can have a better understanding about what is happening across health and care. And finally, in terms of innovation, we remain curious about what's working well and why as systems respond to COVID. and our aim is to share some of that innovation and good practice so that we can help other providers and other local systems better, but also that we can use that in our annual state of care report to give a view on how the system and how health and care is changing. That was my update.
Oh, great, thanks, Chris. Any questions or comments for Chris? In which case, Kirsty, should we move to the change update? Sorry, took you by surprise.
I was on mute.
Hang on, somebody wanted to ask a question.
Peter's Paul, have we gone past the performance report?
No, I think the performance is next on the agenda, Peter. That's why Kirsty looks surprised.
Sorry, yeah, I beg your pardon.
So Peter, I just want to make sure that there was just Mark just to round off the exec team report, and if that's all done, then we'll move on to performance. But Madam and Mark wants to just say anything.
Yeah, only briefly to report that no cybersecurity issues or incidents in this period. And similar to Kirsty, I'll give my update in the change update. Thank you.
Great. Thanks. Sorry, I beg your pardon, everybody, but thank you for stopping me in my enthusiasm to get to the change report. Let's deal with the performance report.
Thanks, Peter. So I'll kick off and just say a few words. This is the end of year performance position. I'll say a few words by way of context, and then I'll hand over to Kirsty and Chris to pick up the detail. But I think the thing that is really pleasing, I think, is we've done a lot of work this year to focus on the higher risk services, and I think we've had some success there. I think if I draw your attention to paras 3.2 and 3.3, for example, in the report, where we talk about the return to rating section, I think this talks to the idea that where we see risk in services, our inspection activity is focused on that. I think the area that we've done slightly less well on is actually producing the reports, although in social care and primary medical services, our report production activity is good. I think the complexities of producing reports in large hospitals does remain a challenge, and we have got work ongoing to look at that, but I think that has remained a challenge, and I think that's in part that's probably because hospital reports are physically bigger and draw on more data sources and require more checking than the perhaps smaller reports. If I look at registration, I think we've talked a lot about registration. I think we flagged some months ago that we knew that the KPIs we went into the beginning of the year with would struggle a little bit as we came out of the year. But I think that's a reflection, I think, of the work that Kirsty has been talking about around the change work that's going on in registration. I'm sure we can talk a little bit more about that if necessary. But I think that is going to be a transformed service over the coming year. I think you'll see those numbers change quite dramatically. In terms of money, we finished the year just underspent, a little over 2% of our overall revenue turnover, and underspend on capital. In large part, I think this is driven by change programs which naturally had a planned back-endedness to them, particularly with things like the Digital Foundations program and so forth, which we knew were going to have a lot of back-end spend towards the end of the year, and the challenges of bringing that in on the end of March. But I think I would draw everyone's attention to the fact we've been through a major set of transitions this year. Sorry, that's my doorbell making a noise. Sorry. Don't have a comedy doorbell. I think we have been through a set of major transitions, particularly in technology terms this year, and I think I'm really pleased with the efforts the team have gone to bring the budgets in on track, and in a number of cases we've underspent on planned budgets. I think it is a reflection of the agile approach that we've taken to delivering a number of programs where we've been able to move activity forwards and backwards, and I think we've always wanted to make sure that if we had to move away from our planned budgets, it was an underspend, not an overspend. And finally, in terms of people, I think turnover and sickness have all come in within the expected ranges. and I think I'm pleased with that. I know we had some challenges earlier on in the year around the people survey, but despite that, I think that has not been reflected in people being absent from work, which I think is a really important point. I think we are still an employer that's seen as a good group of people to work for, and I think that's reflected in some of those people numbers. So I'm going to pause there and invite Kirsty and Chris just to add a little bit more colour to what I've said. Thank you.
Thanks, Ian. Chris is going to take you through the dashboard and also the COVID dashboard, which we set up. I think we may have said last month that at the start of the COVID, we set up a dashboard to track our activities. So Chris will talk through that. I think Ian's probably just covered off most of what I was going to say, but just to draw your attention to the risk register as well. This is the first sort of new risk register with the amended risks, and we're just to sort of say that we are working through this one now in terms of allocating actions and mitigation measures, and we'll keep you posted as we move through the year with that updated risk register. Chris, do you want to pick up and take people through the detailed performance report, picking out some highlights?
Yeah, I'll do that. Thanks, Ian, Kirsty. So going through the pack in terms of the slides that are presented, the main area really to focus on first would be registration, which is slide 5 in the pack, not the diligent number, but slide 5 in the pack. And the story of this year was that the registration entered a recovery phase in November. I think at that point, 5,913 applications were in the system. Now we're at the position where, or at the time of reporting, we're at the end of the year with 94% were complete, with 6% remain. And I think a lot of the work the team are doing is focusing on understanding the activity in order to model and centrally deliver that activity. And as Ian said, we're looking to implement new KPIs to reflect our work in registration. Kirsty, I don't know if you want to talk to the detail of registration a bit more. But
well, I think in previous boards I've talked quite a lot about the work that we're doing to pretty much fundamentally change our approach to how we are delivering the registration service, looking at taking a more centralised approach to triaging and assessing work, so we make the most of the resources that we have available to us in terms of performance and efficiency. I think the other thing just to note with registration is obviously that we've gone through a huge amount of work to address our backlog, which is shown by those figures. The data is not looking so great, because by doing that we've addressed some of the aged, some of the more older applications in the system to enable us to do that, so that we have we've got a more up to date backlog now. And I think you can see that we've worked through most of that backlog. It is also worth registering that, or noting in registration, there's been a huge amount of activity that's come in as a result of COVID changes, and we are working through that quite rapidly now to enable us to respond to those in a timely and efficient fashion. As everyone said, I'm confident that next year, going forward, that registration performance will markedly increase as those changes that we've made start to impact.
Yeah, may I just ask a question there while we're on that particular slide, rather than interrupt going back to later?
Yeah, go, please.
Thank you. Because I was just looking at how that red line is diving down through the floor, and I understand what you're saying about there's lots of work going on around new processes, but in terms of bringing those in, it's going to take a little while to get. I mean, we're starting with some of the smaller ones, but when can we expect to see this line recover as we're in recovery?
So this is new applications. So basically, what was happening in previous times was quite a lot of the more complex applications were taking a long time to resolve, and they weren't being moved forward at pace. And some of the quicker and easier ones were being done, were being brought forward. What we've got now is a different approach to assessing those. So it has gone down while we looked at sort of the process and the backlog and sorting all that out. So a lot of stuff got held while we were sorting it out. We were liaising with the providers, and we were processing the urgent ones quicker, but those less urgent ones we were putting into the queue in order to enable us to do that. I think that line will start to go up. I think it's been impacted quite heavily now by the COVID work that we've been doing as well, because we've been prioritising those applications. So if you took the COVID piece out of the system and we look forward, I'm anticipating that will start to go up again now that we have A, got on top of that backlog, and B, got a new system in place to start to ensure that that work is being done in a timely fashion, and we're getting through them at a pace. I think off the top of my head, some of the more simple ones now we were getting through in a matter of days rather than weeks, and I think we'll start to see that going forward in the coming months. It's just COVID is impacting quite heavily on those figures as well at the moment.
Okay, thank you. But to see that in the future. Thank you very much.
Okay, just to continue, slides 6 and 7 focus on our return to ratings, and in year we've kind of prioritised services rated inadequate and requires improvement. ASC hit KPI here with 84% of services within their rate and frequency. PMS and hospitals were just slightly below target, but that as the slide 7 you can probably see there that's we've seen a steadily performance increase throughout the year, and it's mainly due to the performance at the start of the year that's impacted that target. So just narrowly missing on both accounts there. So I don't know if anyone has any questions about our return to ratings.
Probably just to reflect what the chief inspectors have said in previous meetings when we've asked about this, that even if the target's been missed, it doesn't mean there isn't visibility of the service, and that's probably quite an important point.
Yeah.
Can I just add to that and give some assurance that we've been tracking this on a weekly basis and looking at all of the reasons why, particularly in the inadequate bracket, they were missed. And actually in the last 3 months we looked, and all of the reasons we missed them were due to the external reasons from the provider, such as bereavements in the practice or other things that meant that we negotiated a different date for that, rather than it being related to an internal factor, something we were doing or not doing.
Thanks, Rosie.
Yeah, to continue.
Yes, continue, Chris. Please,
continue. And just moving on in terms of safeguarding on which is slide 10. Concerns continue and improve month on month, ending the year just behind target at 93%. Alerts referred within KPI hit that KPI at 96%, following a workshop early in the year, so to focus on performance. That's a good news story there. Slide 11, just moving on to reports. So in terms of reports, overall 88% were published within KPI, narrowly missing a target of 90%. ASC and PMS, so ASC hit target at 90%, PMS were above target at 93%. Hospitals, as we reported before, were 54%. With an improving position towards the end of the year, but we've, as mentioned previously, we've a QI initiative underway within hospitals that's still underway and still progressing. Again, happy to take any questions or pick up any questions about our reports.
Perhaps I can just drop in there that we've, with the suspension of routine inspections, of course, this is enabling us to clear the backlog, and the backlog is virtually cleared, and by the middle of June, all reports will have been published. And I think that gives us a great opportunity to drive the quality improvement process from a clean sheet when we resume inspections. So I think there's a great opportunity here which we mustn't miss.
Thanks, Ted.
Yeah, and the last bit, I mean, as Ian's covered it already, but the financial position, we ended the year with an underspend slightly above the 2% KPI, and again, as Ian referred to, is the predominantly the challenges with multi-year change programs that straddle financial years. So we've taken that into account in our 2021 budget. But that's the highlights from the report. But happy for anyone to pick up anything within the wider section.
Does silence mean we're all absolutely happy? And does that mean I can now move to the change report?
Brilliant. Thank you, Peter.
Thanks, Kirsty. Good. We get there in the end.
Okay. I got there. I wasn't surprised this time. So, in terms of the public, in terms of the change report, I want to just pull a few highlights for you to start with. I think it's good to note that delivery progress has been made across the portfolio, despite impacts of COVID, where we've had issues with resourcing being pulled away to support COVID responses. We have managed to protect our delivery, and I think we've maintained our cadence of delivery that we were hoping to, which is great. I think there's three programs have hit their critical milestones over this period. Registration Transformation program has launched its first end-to-end digital service in private beta. That's for domiciliary care agencies, and I'm pleased to report we've had over 50 new registrations on that service to date, and 3 or 4 actual full applications coming through, and it's working really well. So I'm hoping that we'll be able to get the applications through that we need to start to move that into public beta at the right time, but a real positive step there. Digital foundations, we've had some key contracts that we've now let, and I'll let Mark talk a little bit more about that as we move forward. And also regulatory platform is moving forwards in a really good way. We've passed the internal approvals for the outline business case, and again Mark will update you on the sort of technical side of the work that's gone on there. In terms of COVID, I think it's really prescient to sort of note that the new technology that we have been working on over the last year or so has really enabled us to deliver at pace to support the COVID response, both through the work that we've done around data collection and also in the development of the emergency support framework. I think if we had been in this situation a year, 18 months ago, we would not have been able to respond in the way that we have. So I think it's really great to start to see some of the benefits of that investment in change starting to work through into our ability to operate and respond to what we find in front of us. In terms of some of the projects that we've got on the stocks at the moment, the transformation vision, which we were planning to launch back in June, back in April of the year, which we put on hold with regards to the people focused on COVID. We're about to go back out and start to launch that across the organisation to really start to set out how our transformation vision lands alongside the work we're doing around our strategy to ensure that so we have a really clear delivery plan to underpin the work on our strategy, and we're launching that with our staff. Also talking about how that also fits in with the work that we are doing to transition through from our COVID current situation through into recovery and out the other side into business as usual. I think the other thing to note that's for the change report this year, this month, is also how quickly we have managed to move our entire operation out from a office, or from a hybrid home-based office model to an entirely home-based model. And our colleagues in HR and facilities have been working really hard to ensure that our colleagues have a good home working experience. We've provided them with the equipment to make sure they're able to work safely, but actually also supporting them through both their well-being and also through supporting line managers to help them recognise actually they need to work differently and manage their teams differently in a home-based environment where they can't see people. And I think that's worked really well. Hoping that the response that we get to our pulse survey that's going out, that's out at the moment, will show that work has been well received. In terms of some of the programs, just a few to highlight. As I say, the Transforming Our Organisation work has now started. This is aligned to our strategy. It's a tangible delivery plan to support our strategy. We have now completed our as-is mapping process that is looking at our current operating model and identifying the challenges that exist within that current operating model and providing us a focus for some of the areas that we want to address as we move forwards with this work. We are now commencing the to-be state, and we're working with widespread engagement across the organisation and with wider stakeholders to start to look at how we start to co-design that for the future, thinking about some of the things that we want to do to ensure that we are a responsive regulator both now and in the future. The work on the regulatory platform, we are working to select our business partner to go forward into implementation, and Mark will talk you through a little bit about that in a bit more detail. And our registration transformation program, as I said, we have launched our new service. The other element of registration transformation program is our work we've done around our continuous improvement. We have struggled a bit with some of that work because one of the areas that we were looking at driving improvements in was our sale and transfer piece. With COVID, that work has pretty much come to a grinding halt. So that area of work has had to have been paused, but what we've done is brought forward some of our improvement work that was on our backlog to ensure that we continue to drive improvements through our registration transformation program in terms of how we operate today as well as how we operate in the future. Our improving regulation today work is looking at how we develop, how we improve and our step change in our project and how we regulate today, ensuring that we remain aligned to the changes in the health and social care sector. There are a number of projects in this programme. The current focus for that programme at the moment is developing our approach to regulating enclosed cultures, which Kate talked a little bit about earlier. Our QI capability programme has again been impacted slightly by COVID, as we were hoping to start to run our silver cohort. That has, recognising that we're probably going to be out of the offices for quite some time now, what we're doing is looking to develop some online training to support our COVID, particularly our silver team, particularly putting together some webinars to enable that silver cohort to start to build and develop capability. And we'll also have our bronze cohort or our bronze online offering available to start to build the QI sort of understanding across the wider organisation. Moving on to people. Obviously, I've talked a little bit about the work we've done to support people during the COVID piece, as well as support people to go out on secondment who are keen to return to frontline services where they have clinical skills that we can offer, and we've been facilitating that to enable people to go out and do the work that they want to do in that space. Our people plan, which is our overall sort of a holistic plan in terms of addressing our work around our people, to build capability and capacity across the organisation. That is starting to take shape now. We've pulled that together into a tangible programme with some clear benefits and deliverables associated with that. A couple of things just to highlight through that work. We transitioned into a new payroll provider, which was Northumbria Healthcare last month. Payroll worked without any trouble, which is always a relief. But actually, I think it's a real testament to the people working behind the scenes and our new provider, how smoothly that went. If we hadn't told anyone, I don't think anyone would have noticed, which is always a sign of a project well delivered, I think. We have developed our new dashboard, which is providing real-time performance information for line managers and leaders to support decision-making in the HR front, bringing together all our HR metrics into one place, utilising Power BI to really give an interactive and dynamic approach to supporting our information around our people. So we launched our pulse survey last week. This pulse survey gives us a bit of a temperature check across the organisation, and it's the first one of a number we are planning on doing over the coming months. This one has got questions that were common in the main annual survey to enable us to track performance against those key metrics, but also we're exploring how people have felt around the COVID response and also checking on our well-being of our colleagues. So hopefully we'll be able to have some headline results when we come back to board next month on that one. In terms of building our leadership capability, this is a key tenet of our people plan. We have been doing quite a lot of work on this over the last few months, and one of the key elements of that, one of the key deliverables, has been success profiles, which is setting out the sort of behaviours and competencies we want to see at each grade in the organisation to really start to provide a sort of framework for the future. We have now completed this work in draft. It's been quite a big consultation exercise across the organisation with lots of workshops at the various grades, setting out what they see as the key behaviours for success in their roles. and we've now brought that together into a set of draft profiles. We're now starting to finalise those and look to how we embed those into the organisation to support both career talent management and also performance management going across the organisation. And I think it'll be a really strong plank to support recruitment and ensure our recruitment there is a level playing field for our recruitment alongside some of the recommendations that came out in the work that we did with the on our D&I strategy. Reward and recognition work is progressing well. We are currently looking to determine both what our sort of short-term and longer-term approaches to reward and recognition, and we want to do this work to ensure that we remain an employer of choice going forward, so that we're able to attract and retain the skills and capabilities we need in the organisation just now and also in the future. And I think we're making good progress in this space. Next quarter, our focus is on launching our transformation vision and also the work we want to do on our recovery programme to support the transition through from our current COVID response and back into business as usual, whatever that might look like. Launching our success profiles across the organisation and also starting the work on the cultural inquiry that you've heard a bit more and starting to launch those workshops going forwards. Mark, I don't know if there's anything you want to pick up on your bits around the technology.
Thanks, Kirsty. Just a couple of additional bits to what you've discussed. So on digital foundations, we're making really good progress on some of our core activities there. So we're doing a significant migration of our applications from on-premise infrastructure into modern cloud infrastructure. That's progressing very, very well. And we're also finalising that work to transition our core IT support services to our new provider, which is going to make a big difference to our colleagues, and that's expected to go live during the next month. I'm also really pleased with what that team have been able to achieve, given the additional challenges that COVID has presented to us during the last couple of months, and the additional burden and the logistical challenges of supporting all of our colleagues from home, which we've been able to do really successfully. On the regulatory platform, as Kirsty said, we're now in the final stages of procuring our implementation partner, which will help us configure the new Microsoft Dynamics platform to meet our regulatory activities, and we've also been working on all of the design work that's needed, our as-is and to-be process designs, our data designs and implementation plans, as well as setting up our teams and our governance as well, which has all gone very well. And I just wanted to kind of just talk a little bit more about the emergency support framework. That's been a real success for us in terms of us demonstrating that the new technology that we have enables us to do things at incredible pace. So the underlying platform that we're using is a Microsoft Dynamics platform, and we've been using the excellent Microsoft Catalyst team to be able to help us to stand up that technology incredibly quickly, and that's enabled us to manage all of our solutions in response to COVID-19 with support for testing, booking, for data collection for home care providers, and also is the foundation for the emergency support framework. And as Kirsty said, that technology allows us to deliver services at a really incredibly accelerated pace using what is essentially configurable low-code platform that allows us to move at that speed whilst delivering the secure and robust solutions that are scalable and perform very well. So it's a good test of that technology for us, which we're really pleased with.
So it seems to me that both the scale and the pace of the activity across the whole change programme, as well as the technology piece, is just fabulous, and I personally would congratulate everybody. We obviously have a lot of oversight and sight of the programme through the ACGC and the subgroup, but are there any questions that board members want to ask now, or observations they want to make?
An observation, Peter, if I may.
John, please.
Just to underpin and underline how impressed it is to maintain delivery at a time when people are stretched, and at the same time create new things at speed. And the agility, robustness and pace of that gives us, demonstrates the resilience that has been built in and gives us confidence for the future. But I would also suggest is an exemplar for other organisations in the system who have a requirement to similarly deliver in the way we have. And thank you to all of you for doing that.
I couldn't possibly comment on that last recommendation, John. Anything from anybody else?
Yes, please.
Mark, please.
Yeah, can I just echo what John said there? It's really impressive, and Kirsty, thanks for a really full report. Just in terms of the people plan, really good news to see mental health advocates being put in place and trained under inclusion and well-being. So well done for that. And great to see some of the sort of virtual programs starting. We heard from Kieran that, as you've mentioned, bronze and silver QI programs. And the launch of ESF using e-training, and of course the Pulse survey. I just asked the question, Kirsty, whether we're looking at other people processes to make those or to digitize those, such as appraisals, career development reviews, recruitment and onboarding.
Thank you, Mark. So yes, we have as I'm sure you can imagine, that there's a whole heap of things that we want to do, and we've got to just sequence them. So I think some of the work around recruitment, some of our HR processes that we could definitely do more around digitization and automation. We want to look at that, but I think it's about our broadband and our capacity to pick these up. So I've been having conversations with both Jill and Chris about what a future integrated HR and finance system might look like, and how we might look to build that in the future at some point to enable us to do some of this stuff. Also looking at where we can automate some of the things, and there is quite a lot of new technology out there that we can build in to help us with that. We are just starting the robotics piece in our NCSC centre to help us process quite a lot of the sort of notification work that we have. I think there is loads of opportunity for us to start, once we've tested our toe in the water there, to expand that work both into the HR side of things, to really make sure that people have a really good experience and a quick experience where we can do that. So it's definitely something on our agenda. I think it's probably more, we're pretty full up with the people plan this year if you look at the breadth of what we're doing. But always looking ahead, all those sort of things that I think we're going to plan in for next year to enable us to build on what we've done over this period of time.
Yeah, no, Kirsty, thanks. I wasn't for a moment suggesting there was slack in the organisation, but I was just thinking in terms of recruitment and onboarding, there still will be the need to bring people in, and in an environment that we're in now, then clearly e-recruiting and e-onboarding are critical measures for us to have some success in that area.
We have quite a lot of online processes already. They're maybe slightly clunky, but we have a lot in that space that we can do. And at the moment, our recruitment is pretty small because we've paused a lot of it through the COVID. But we'll start it we'll get it back up and running again, and it'll work quite easily remotely. In fact, we have had a few people that did join right at the beginning of COVID, and we managed to induct them, bring them on board all remotely, and I've had personal feedback from some of those recruits that actually it's been really successful, and it's worked really well.
Great, thank you.
Anything else on the change update from anybody?
Peter, I just want to sort of add my thanks to my executive executive team colleagues for the fantastic work that's been done this year. I think we skated over simple things like a new payroll system or a completely new technical architecture. These are things which in most organisations you do one, you wouldn't do them all. But I think it is very much a team effort, and I think the way we've been able to respond to COVID has been really an aggregation of all of the things that we've been doing, and a change of culture and a change of approach from the whole organisation around how we take a programmatic and a more systematic view of change. And I also want to record my thanks to non-executive board members for the support you've given us on and the patience you've shown when we've been talking about agile programs and moving at pace and moving things backwards and forwards in the change program, and you've borne with us on that. And I think if you look at the performance across the year, both in terms of operational performance and change, I think there's some really good stuff there. There's of course things that we still want to improve, and I think there's a collective impatience to do that. But I think it feels like a good end of year set of numbers is my sense. So thank you.
Thank you. So we'll have a pause for some lunch. If we start again at 1:45, which is the scheduled time, and Mary Cridge and colleagues are joining us, so that's about a 5-minute less than advertised break, but I hope that's okay. And I'll see you all in 25 minutes. Thank you. I'll assume we are. So can we restart? Can I welcome Mary Cridge? Mary, you are going to give us some reflections on your time as our Speak Up Guardian, which has come to an end. Can I also welcome Julie, Uma and Carolyn, who are going to take over from you. I always think it's very flattering when 3 people have to take over from one person. So there we go. Mary, shall we start with you, please?
Okay, thank you. Well, thank you very much for the invitation to share my reflections. I've sort of rounded them down to 7 key reflections, and once I've gone through them, I'd be very pleased to hand over to Carolyn, Julie and Uma to introduce themselves to you ahead of bringing the 6-month report to you next month. Good. So number 1 on my list is the reflection that we really believe in speaking up, but we don't always live up to our own expectations. I think the board can be certain that we've got genuine, heartfelt commitment to this agenda. It's felt to be wholly in line with our values. And we know from research, though, that we're braver speaking up for others than we are for ourselves necessarily. But as a guardian, to be in a place where Speak Up is respected, encouraged and nurtured is really very special. And I doesn't always mean I've got the outcome I was hoping for on behalf of others, but it has been a very supportive place to be. My second reflection is that speaking up is relational, and that just like all good relationships, it needs to be worked on and nurtured. It's not enough to be a nice person and a great listener. We have to actively invite people to speak up to us, and then we have to respond well when they accept that invitation. And I think we've made some really good progress on this. There's a phrase now in CQC about disagreeing well, which I think is a great thing. We've learnt a bit about understanding how scary we are, about sending shut up signals that can range from body language, expressions that show impatience, or indeed a diary so busy that no one can see when they could possibly get a moment with you. And we've had some really good leadership conversations about that. And I've seen habits change. And I think we've got a growing understanding that this is the heart of safety for any organisation, not just those delivering care. I think at the start it was thought we don't deliver care, so how is Speak Up for us? I think that feels really old-fashioned now. We're way beyond that. My third reflection really goes to some of Michael West's work around compassion and performance cultures do go together, although some people find that surprising. Michael West's work has really been helpful in busting some of the myths around this. And the myth being that there's any sort of choice between courtesy and kindness and effectiveness and getting things done. And the Civility Saves Lives movements, which I've talked to the board about before, has given us new insight into the impact on our own individual performance. We don't even have to be on the receiving end of incivility. We only have to witness it, and there's a short-term impact, which we want to so avoid. And I think in this space, it's email that's the big danger for us. I think I have never personally witnessed any incivility between colleagues in CQC, but I've certainly seen emails that are curt and sent when folk are tired and all the rest of it. Which one of us could say we haven't ever done that? So I think care with communication is so important and a big reflection. My next reflection is the guiding lights that have really made a difference, and I've not been short on inspiring people around me. So everyone from Sir Robert Francis, Henrietta Hughes as our National Guardian, Professor Megan Rees, the many guardians I've encountered on hospital inspections, and the people I've worked with in CQC. So whether it's been help with understanding where this started, the high stakes, what good looks like, what to avoid, and feeling part of a bigger movement, that has felt really special. Next on my list would be the staff equality networks and recognising and reflecting on the part they've played. We've recognised we've got a shared agenda. That wasn't always obvious from the start, but it certainly is now. And I'd include the staff forum and trade unions in that group. We've had a sense that we're all in it together, and it now seems so obvious that the agenda is shared. And we even share a month of October, being both Black History Month and Speak Up Month. And we've done some joint events, as we have for other special weeks and months for the other diversity networks. And I'm very grateful to them for their support. Ambassadors have had a real impact would be my next reflection. I've been blown away by this group of people, and I think individually and collectively they're really having impact now. Some of the individual speak up stories that we heard from people on the ambassador training were so humbling and inspiring. And some of those experiences brought people directly from provider organisations to search out regulators to be part of it. So we've got within our own organisation, we have some amazing stories. My final sort of reflection is that we have moved the dial. I've got a phrase about when in doubt, look at the data. And in my very first appearance at board, and answering the question about how we would judge success, I nailed my colours to the People's Survey mast, and specifically the question that says, I think it's safe to challenge the way things are done in CQC. So when I started, that was 42%. And it stuck at 42% for the next couple of years. But in our last survey, it was the second most improved score. And we increased by 6% to 47%. Obviously, that isn't where we want to land. And within that, there's a huge variety of experiences for people in different parts of the organisation. But it's a really significant improvement, and it's been hard won. So that is my, I've galloped through them, but to allow some time for questions. But that is the sum of my reflections. It's been a huge honour to hold the post, and I thank you for the support that you have given me. And I'm leaving the next stage of development in very, very safe hands with the three new guardians who've been appointed.
So, Mary, I think it's our thanks to you, because I think you've done this on top of having an incredibly large day job, as it were, and you've given a huge time and direction and impetus to it. So I think we're all incredibly grateful to you. Can I just ask you to amplify your first comment, which was that we believe in in speaking up, but we don't always deliver it, I think, or words to that effect, you said.
Yes.
Can you just amplify that comment a bit?
Yeah, so I've got sort of two sources for that. One would be the research that we participated in, part of Megan Rees's international research, where the results that came up were so average that she actually doubted them and had the data rechecked. And when we discussed those at board, there was some disappointment, but thinking that in our role as a regulator, we might actually have been better than this. And in fact, as a regulator, when I think of the community that I work with, there is no lack of bravery in speaking out on behalf of others. But when it comes to internally, the research showed that we were solidly average, which just means that all the barriers that exist in every organisation exist for us as well. And it is a case of having things in place and habits to go along with the policies that we have. So I think that was a bit of a wake-up call for me and for others that actually we have got room to move. There's also, I suppose, the very human side of this, that I think people are very deliberately trying to get this right. But, you know, then Megan Rees talks about this. She says about, you know, as leaders, we might get this right 98 times out of 100, but the couple of times we don't get it right is what people will notice and is what's talked about at the water cooler. So I think we're good in CQC at recognising that we are human, and I think this is never going to be perfect. I would point to something I said further down around learning to disagree well and being able to have that compassionate conversation and cut each other slack on those days when we aren't the best version of ourselves. But I hope, you know, we are definitely moving in the right direction.
Oh, thank you. Can I invite anybody else who wants to ask anything? Mark?
Yes, I'd love to ask you a question to Mary, please. Mary, thanks very much for this report. I'm very interested in your point about communication, and I must put up my hand that I've sometimes sent an email that I shouldn't have sent, and I take that on board. But on a serious note, have you noticed a spike in engagement with Speak Up Guardians during COVID? And if so, how have we been managing that in terms of having to use a digital format for engagement?
We haven't had a spike. In fact, the other way, it's become quieter. There has been an active discussion of Speak Up on some of the all-staff calls, which has been good. We're definitely alert to it looking externally for staff in provider organisations speaking up. I am in fact aware of a number of cases at the moment where people have actively put the things they want to say on hold, recognising how busy everybody is at the moment and how there are bigger fish to fry. But they're saying, actually, this is important to me, but I'm going to hold on to this for a bit, and we'll take it up when we're a bit further through this crisis.
Yeah, that's interesting. I hadn't really grasped that, and I understand that. I just wonder how you capture that going forward, so that, you know, those issues that are important that have been put on the back burner still get through your role and your colleagues' roles.
Yeah, so we do keep in regular touch. The ambassadors and myself, we keep in regular touch with the people that have been having the conversation. So we will make sure that we don't drop any of these balls.
Thanks, Mary.
Yeah.
Peter, could I have a word? Just to thank Mary for tremendous work and a couple of reflections of my own. One is that I love the phrase disagreeing well, and it seems to me at the heart of the freedom to speak up is the necessity for all of us to learn that there's nothing wrong in disagreeing with each other. What is wrong is suppressing what someone else wants to say not listening to them. And that can happen both intentionally and unintentionally, and I think that's a really good phrase. And the second reflection is that, and this isn't meant as reassurance, but it's become clear to me really since the Freedom to Speak Up review that these are problems, the problems of implementing a freedom to speak up culture are common across every sector, every walk of life. And the reason for that, I think, is because human nature resists receiving criticism, or what is perceived as criticism, and therefore deals with it as a threat rather than as a valuable resource. And it seems to me that we as regulators have a very special responsibility to get our house in order, as we are seeking to do, in order that we can exemplify to the world we regulate that it is possible to do this, because I'm not sure everyone believes it is. But the health service generally, I think, is getting better. And the final reflection is, and again it comes out of what Mary's saying, is that like with everything else we do, you do need patience, probably more patience than I really have, frankly, but none of this happens quickly because people's behaviour does not change quickly. But we, I think, are doing a great deal towards making sure that that happens. And Mary, you've had a great deal of contribution to making this, and thank you very much.
Thank you.
So it does seem to me...
Can I ask a quick question?
Oh, sorry, go on. Yes, please, go on.
Hi, Mary. I'm not actually sure if this is going to partly be for Mary and partly be for the new Freedom to Speak Up Guardians. I had a mental query at the start of lockdown that I was going to be very curious as to whether, and I know you cover more than bullying, but whether instances of bullying and harassment were going to go up or going to go down during lockdown, whether people being physically removed from a situation would ease it, or whether interaction being over Teams or virtual interaction in a way that is less witnessable than office interaction is would actually increase it. So I would be interested, you've said that you have people who wish to speak up about things but are putting them on hold at the moment, but I would be interested in knowing further down the line, when you've gotten a better idea of who is talking to you and about what, whether people's experiences of bullying and harassment that they are prepared to come and talk to yourselves about have changed due to us shifting to home working.
Thanks, Beth. Can I just, before the Mary or the three new guardians answer, can I just broaden that? Because what I was going to say was, I think it's really interesting for an organisation that has a very large part of its people working permanently as home workers to understand what we've learned through the lockdown, both good things and bad things. So, Mary and team, if you would like to answer Beth's comment, but sort of broaden it out if that's appropriate.
Gosh, okay. So, I think, well, I haven't got any hard and fast information on this. I think it's a really interesting area, and we can actively seek this out. It has been apparent on some of our all-staff calls that some colleagues, in what they've said and the way they've said it, are clearly struggling in some way or another. And one feature of our means of broadcasting to people is people are able to comment and make questions, and they can do so anonymously. And there was quite a bit of discussion about how many comments were being made anonymously, and the discussion went from irritation with that to an understanding that these are people in some distress, potentially not used to home working, and what could we do to support them. And Ian addressed that head on, as did other members of the executive team who headed up the calls, and encouraged people to make comments with their names against them so that they could be supported. The gratifying thing from that was just what a difference it made, and the number of anonymous comments fell off fell off a cliff, really, and there's only just a few left. We also invited Henrietta to be part of those calls, and you know, she reinforced how important it was just to say what you're thinking and feeling. So I think where it has shown to be an emerging issue, it has been addressed head on, but I think there'll be lots of learning for all of us about positively and less positively around this period, and we can certainly in the Speak Up world do some work about that. The ambassadors will be a very good source of information for it. So,
because we're running out of time, but I would like just to give Julie, Uma and Carolyn the opportunity just to say hello. I don't know if they've all got such smart offices as yours, Mary, or
Definitely not.
Do you want to each say, you know, sort of, I mean, I know you anyway, but just for everybody who doesn't know you, do you just want to say, you know, one minute each on who you are and why you volunteered to become our guardian?
Shall I go first? It's Julie.
Yeah. Yep, go for it.
Okay. Thanks very much for inviting us to introduce ourselves. And I'm Julie Lindsay Ayres, and I work as an adult social care inspection manager. And I'm really proud to have been appointed a Freedom to Speak Up Guardian for CQC. The reason why I wanted to do it was because I've been in a position in a former working life where I wasn't able to speak up, found myself having to walk out of work, leave myself financially in a lot of trouble, emotionally in a lot of trouble, and I didn't have the policy or network to support me to speak up and protect myself and my family and the people that I was caring for at the time. I can almost echo Sir Robert Francis, what he was going to say. I've written down here about us being the regulator and about us having exemplary speak up policy that basically we can be proud of and that can be replicated. So thank you very much.
Thank you for volunteering, if that's the right word. Carolyn, do you want to go next?
Yeah, thank you. Hi, everybody. I'm Carolyn Jenkinson. I'm one of the heads of inspection in the Hospitals Directorate. I cover the London acute sector of the directorate, and I'm, you know, like my other two colleagues, I'm really proud to have been appointed as a guardian, but I'll let you into a little secret. One of the reasons that I applied for the post was because I wanted to get a little bit more exposure to the board, so this is like my dream come true, and I've ticked a box. I'm going to be we've all sort of carving up some lead responsibilities in our roles, because obviously there is the three of us, and I am going to be the person that has a bit more to do with the board, hopefully, if that's okay with you, Peter, and I look forward to working with you a lot more. I think I also am in a privileged position, because obviously as a head of inspection in hospitals, I get to, as you know, my day job, go and look at how boards function and look at how Speak Up works within NHS Trust. So I've seen some great things, and I've seen some not so great things.
So you're really welcome, and I just hope we don't shatter too many illusions. The closer you get to knowing us. So anyway, you're last but not least.
Thank you, Peter, and thank you everyone for inviting me to the board. Like the others, I'm really excited to be part of this role. Why I was interested in this is a story that perhaps is a few months old. I joined the Leadership Academy for a leadership training course, and that was actually directed more at British and minority ethnic candidates. And I wasn't really looking for anything particular in diversity. I was really only looking at general leadership. But what I heard during the course from my fellow workshop colleagues was really an eye-opener to the kind of discrimination and the kind of problems that are there in the NHS. And that got me really interested in understanding why people are finding it difficult to speak up. And I always thought CQC was a wonderful organization in terms of the well-being policies it had in place, in terms of the way we look after our people and ensure that there's support really for everyone. But then, like Mary, I started to go back and look at some of our staff survey results, and just realized that while we've got the policies, some of our staff perhaps don't perceive us living up to those policies as well as we could. And which is why I really thought, if there was anything that I'm learning from what I'm doing, then I'd really like to contribute to that. So I am looking forward to working with everyone, with my colleagues, my other two colleagues, as well as everyone in the board.
Great, thank you. So Mary volunteered that you'd be back in a month's time with a report. I don't know if that's all three of you or just you, Carolyn, but anyway, that whatever, we will see more of all of you over the coming months, and anything you need from any of us, you just have to say, because going back to Mary's opening statement, we really do believe in speak up, and if we're not always living up to it, then we need to work out how to do better. So thank you all very much, and Mary, we will see you again, albeit with a different hat on, so thank you as well.
Thank you all.
Thank you all.
Thank you very much.
Thank you.
Thank you.
Bye.
Thanks. Bye-bye, everybody. So that takes us, I think, just to any other business, if there is any other business from the board. So we end the formal board meeting at that point. We do have one question from a member of the public, Robin Pike, which I will read out because it's relatively short. I understand the CQC currently has a role in facilitating access to independent hospitals by NHS patients for their elective surgery. How will this access work? Will it require authorisation by local commissioners? And I think probably, Ted, you're the best person to answer that.
Yes, thank you, Peter. So first of all, can I just start off by saying that independent hospitals have been really very, very positive. What they've done is really, in supporting the NHS response to COVID, has been really very positive. And I want to congratulate them on lots of very good work they've been doing. They are essentially providing support for the non-COVID services. That's a generalisation because different hospitals are doing different things, but essentially they're providing a support to non-COVID services. And if you think about some of the issues we were talking about earlier on in terms of infection control, there's a real opportunity for those hospitals to be the COVID-free environments where elective procedures can be undertaken or cancer care can be provided. So I think they are going to be extremely important in the recovery, and I'm very grateful for the work they've done. Speaking to the independent health providers and the NHS providers, they are generally paired together. So the local independent hospitals are paired to the local NHS trust, and patients who are who've been referred to care for the NHS trust will be transferred seamlessly to the independent hospital where necessary. Sometimes that will be the independent hospital providing care. Sometimes the NHS trust will be providing care within the independent hospital. So it's going to be different depending on the care provided and the local arrangements. So the access for any patient is through their normal referral to their NHS trust. The NHS trust will manage the process to make sure they get the care they should get in the appropriate environment. And this is one of the things, of course, we as the regulator are going to be monitoring very carefully to make sure that as we discussed earlier on, that people who need care for non-COVID conditions are getting the right priority.
Great, thanks, Ted. That's excellent, and that ends the public board meeting session. So thanks for that.